नमोजी आद्या वेद प्रतिपाद्या जय जय संवेद्या आत्मरूपा देवा तूची गणेशू सकल मती प्रकाशू म्हणे निवृत्ती दासू अवधारितोजी. आज आषाढी एकादशी, अवघी दुमदुमली पंढरी विठ्ठल नामाने. त्या काळात आपल्या संतांनी भक्ती मार्गाने लोकांपर्यंत ज्ञानाचा महासागर पोचवला होता. त्यांच्या अभंगातून नाचू कीर्तनाचे रंगी ज्ञानदीप लावू जगी शमदमकळा विज्ञान सज्ञान परतोदी अज्ञान नये घरा ज्ञानदेवा सिद्धी साधन अविट भक्ती मार्ग नीट हरिपंथी. त्या काळी संतांनी आपल्या जनतेला जे काही ज्ञानरूपी ज्ञान सगळं दिलं होतं, ज्ञानेश्वर तुकाराम नामदेव या संतांनी, तर त्याचीच आता आज आषाढी एकादशी असल्यामुळे मी तुम्हाला थोडंसं सुरुवात करून दिलेली आहे. तर गुड मॉर्निंग सगळ्यांना आणि वेलकम टू दिस आवर CME ऑन इम्युनोहेमॅटॉलॉजी अँड ट्रान्सफ्यूजन मेडिसिन अपडेट in association with JANAKALYAN blood center. Welcome all delegates. So CME booking is now online. Avoid queues at the spot registration counter on the day of CME. Avoid crowded traffic conditions for coming to IMA office to pay for registration. हे लॉग ऑन टू दिलेला आहे तुम्हाला वेबसाईटचं www.imapune.com. Join social security scheme of IMA-MS and IMA headquarters. Secure future of your family. You can pay fees today at the counter. For inquiry, our eminent IMA senior members are there. Dr. Jayan Naurange sir, Dr. Shyam Damle, Dr. Suhas Nene sir, and Dr. Amrish Shahade, who is a secretary. So today we are having the CME on immunohematology and transfusion medicine updates in association with JANAKALYAN blood center, and convener is Dr. Atul Kulkarni sir. So I think we will go with the further few our future announcements. So upcoming IMA CMEs and programs, we are having the next Sunday we'll be having seminar plus means online hybrid CME on Save Your Practice. It will be all medical legal subjects will be discussed by eminent medical legal experts. Then we are most awaited UConn is there on 27th and 28th August at Royal Connaught Boat Club, Pune, and it is by WDW conference. Though it is the WDW Women's Doctors Wing Conference, males are also invited. So open for all IMA doctors, and the theme is Women's Holistic Well-being. To join new membership, you can please fill up 3 forms and sign at 2 places on each and paste photos on each, and attach your MMC and MCI registration certificate. And for couple and married women, xerox of marriage certificate or similar proof is needed. And please draw check in favor of Indian Medical Association. So with this, I think I'll be just discussing about the UConn. We are having UConn on 27th and 28th. It will be an academic session along with cultural extravaganza. So we are having dance, singing, Kavita Vachan, recipe contest will be there, Rangoli contest will be there, essay competition, painting competition, photography competition, and there will be a women's health exhibition, as well as the very entertainment program like fashion and fitness show plus ramp walk. And we are having Go-Go Girls, so that is online. You can walk and or cycle or run daily, and you can take part in that. So that is also there. So with this short introduction, I will request our president, Dr. Meenakshi Deshpande madam, to come on the dais and give her opening remarks.
या थँक्यू. पहिल्या प्रथम आषाढीच्या शुभेच्छा आणि मुस्लिम बांधवांना बकरी ईदच्या शुभेच्छा. आणि आज आपला हा हायब्रिड CMEचा प्रोग्राम आहे जनकल्याण ब्लड बँकेबरोबर. And I'm very happy to announce that we are doing this program along with a blood donation drive, which is now going on upstairs in Paranspe Hall. And people for blood donation program have come, and you can all join as soon as possible. Donate blood and then come to the auditorium. That will be my request. And I will now start with some of my president's remarks, which we had in the last month. First of all, it's a proud moment for all of us at IMA Pune to share that the prestigious national award by IMA headquarters, the Doctor of the Decade Award 2022, is conferred upon our Chairman Trust Board, Dr. Avinash Budkar sir. So a big clap for him from all of us, from IMA Pune to Dr. Budkar sir. We are very proud of you, sir. And you are a dynamic, dedicated, and inspirational leader. And of course, you are a lighthouse to many of us aspirants in IMA. Heartiest congratulations also to all the young graduate doctors who have passed their postgraduate exams with flying colors. And kudos to their proud parents. It was a very tough time for them, we know, and we appreciate their grand success. And we also now hope that they join hands with our junior doctors network, the JDN of National IMA, the Maharashtra State Bank, which is getting activated. And we are having the junior doctors network coming with all the conveners, co-conveners, coordinators, college representatives, all coming together and forming a damn good group of junior doctors network. We have got IMA Pune Zonal Coordinator of IMA JDN, Dr. Aditya Rodge. And you can also contact Dr. Ajay Saha, who is the chairman of JDN of Maharashtra State. And we have received many accolades now for our Rangarang program, followed by our Foundation Day program, which we had taken from 29th May onwards to 5th of June. And started with a walkathon. It was there from the DP Road, from Rajarampul. Then it was then followed by No Tobacco Day CME. And then in the evening, we had an orchestra, which was coordinated by Dr. Nanda Kishore Mantri. Then on the walkathon was coordinated by Dr. Kedar Patil in the morning and Dr. Sunil Ingre, Dr. Sanjay Patil. Then on the 31st of May, we had a very grand program of Doctors on the Everest by Dr. Raghunath Godbole. And none other than Mr. Sunandan Lele was the chief guest for the program. And this also has received a lot of appreciation from all over the Pune city and out of Pune city. Then we had got on 5th June in the morning for the program of IMA Foundation Day, we had an exhibition, art exhibition of all IMA Pune members, followed by a recipe contest. And that also has taken quite a good initiative, because we had got many new members participating in this. And they were appreciated by none other than Dr. Budkar sir, who had inaugurated this art exhibition. In the evening, we had got a Rangarang program organized by IMA Pune Art Circle. Dr. Mohan Joshi and Dr. Geetanjali Sharma had done a wonderful job, and they have really managed to all convince and take the participation of many IMA Pune members. And here also we have got many new members coming and participating, showing their talents, and of course getting appreciated. And we had actually put a time limit for them, but later on, as we found out that yes, time limit was a very minimal thing to be done, but 30 p.m. And the hall was also very much appreciating, the audience were appreciative, and we have got good accolades from all over Maharashtra state, inclusive of a special letter of thanks to me and a appreciation letter by Dr. Suhas Pingre sir, who had come as a surprise guest. And he also gave us a letter afterwards saying that this was a very good program. So thank you, Dr. Suhas Pingre sir, for that. Later on, we have got a mail from IMA headquarters regarding the NMC regulations. And the NMC regulations draft, which was kept in the public domain, which we were supposed to give a response to. So then by say 19th or 20th of June, we had received a mail from IMA headquarters stating that the draft of the regulations response has been drafted by Dr. Ved Prakash Mishra sir for all our IMA members. And all of it was sent by us to all the IMA Pune members to be sent from their own email IDs personally to the designated email ID. And all of us must have done that because we have to project our response to that in time. Otherwise, how will the amendments take place? And how will we be saved from our future practice? So with all these words, I would thank the JANAKALYAN Blood Bank for today's TME, and they have involved a lot of people today. And yes, before I wind up, a few words about UConn. I thank you all because we have got more than 100 registrations for UConn today at early bird. And that is a really achievement because there is still 1.5 months to go. And I would request all the lady members here to register for UConn as soon as possible, because this is a conference with a difference. It involves academics, fun, entertainment, plus 4 MMC points. Plus it involves all the participation of gents doctors also, because they can also participate in essay competition, the ramp walk at the fashion fitness show, which will be taking in the evening. So friends and guys, gear up. This is a Maharashtra State Conference, which is hosted by IMA Pune. And I would welcome all the women doctors to it. There will be severe good fun. And also we will encourage our men doctors, gents doctors, not only to come, encourage, cheer us, but also to participate. So thank you all. And back to the secretary.
Sorry, I just forgot to tell you that today we are celebrating Doctors' Day. So we are felicitating 5 of us, our doctors, senior doctors, and we are giving them Doctors' Day award. So the doctor, hand surgeon, Dr. Vishwas Patil sir, then senior physician, Dr. Abhay Mule, then senior physician, Dr. Lily Joshi madam, Dr. Kalpana Baliwanta, AMH, PMC. She's a assistant medical officer of health, PMC, and our own beloved and dynamic young immediate past president, Dr. BL Deshmukh. So with this short thing, I will request now our trustee, JANAKALYAN Blood Center, Pune, Dr. Avinash Vachasundar. I just remember that he has been we had felicitated him in the last Doctor's Day program. So Dr. Avinash Vachasundar, please come at the dais. You are welcome, sir. And today we have kept books on before scolding your child. So that also you can collect. It has been given by Shanta Vaidya Foundation to us. So you can take that book at the registration counter. It will be available. Thank you. Yes, sir.
आषाढी एकादशीच्या निमित्ताने आपण आजच्या दिवशी सगळे एकत्र जमलेले आहोत. खूप आनंदाची गोष्ट आहे. जनकल्याण ब्लड बँकेच्या साठी तर्फे हा कार्यक्रम आज आपण घेत आहोत. इथे JANAKALYAN Blood Bank is a different experiment, as I say always. Medical, social, economical, research, all the things are in this project. And we really do a lot of work in all these subjects. And I personally feel that as a clinical practitioner, everybody should know what is happening in this region, and for that every year we try to have this program. Last 2 years we couldn't have because of Corona, COVID, and this year we have planned this. I welcome you all. I request you to participate in all these sessions. I'm sure you'll get ज्याला काय म्हणू आपण, जसं तिकडे पंढरपूरमध्ये वारकरी सगळे रंगलेले आहेत, तसे या ठिकाणी आपण वैद्यकीय क्षेत्रातली मंडळी या ज्ञानाचे कण एन्जॉय करूयात आणि त्यातनं खूप काहीतरी आपल्याला मिळेल अशी मला खात्री वाटते. धन्यवाद.
थँक्यू सर. Yes sir, because we'll be starting the first panel discussion. Before that I just want to tell you that आपण आतापर्यंत फ्रॉम एप्रिल डायबिटीज, ब्लड प्रेशर, हायपरटेन्शन डे सेलिब्रेट केला, अस्थमा डे सेलिब्रेट केला, Then hypertension also we had a CME. Then with diabetes we had a module, 12 module diabetic online certificate course. Then with this, now today we are taking a very important topic, immunohematology and transfusion medicine updates. And we are having today 6 panel discussions. And the first panel discussion will be starting what clinicians should know about blood and transfusion. So for that, moderator, Dr. Tanvi Yardi is there. Yes, you are coming, madam? You're coming on the dais? Dr. Tanvi Yardi, madam? Yeah, you can start. Yes, madam, you come. Please come on the dais. Yeah. She's the moderator. She's a specialization in transfusion medicine. She's working at JANAKALYAN Blood Center. And at present, she's a quality manager and technical head. She's got a 9 years experience in this field and special recognitions as NAB assessor for blood banks. So with this short introduction, I will introduce other speakers. Dr. Prachi Sathe. I think she's well known to everyone. No, she doesn't require any introduction. But with this honorary, she's an honorary professor, Department of CCM, D.Y. Patil Medical College and Research Center, Pune. And she's a director, Department of Critical Care Medicine, Ruby Hall Clinic, Pune, as you know. And international fellow in intensive care medicine, Royal College of Physicians, Edinburgh, in 1991, fellow of Royal College of Physicians, London, ex-president College of Critical Medicine, India, and then founder member and ex-vice president, Indian Society of CCM. And he's then I will speak upon Dr. Samir Melenkari. He also doesn't require any introduction. He's a hematologist and he's working at present at Dinanath Mangeshkar Hospital and Research Center. And he's got a 25 years of experience. And his special interest is in stem cell transplant. Then Dr. Sejal Khandelwal. She's an anesthesiologist and she's got a 25 years of. So today we are having all eminent speakers to discuss this topic. So let us know from. Yes, I'll be. I will request Dr. Samir Melenkari to come on the dais. Please, sir. Welcome. Yeah. And Dr. Prachi Sathe, madam. Please come on the dais, madam. Yes. Now I will hand over the mic to Dr. Tanvi Yardi. Yes. Dr. Sejal Khandelwal, madam. Yes. Sorry, madam. Yes. Start.
Namaste and good morning to all respected doctors. As previous dignitaries have mentioned, it is a special day for Maharashtra Ashadi Ekadashi. आपल्या विषयाची जी पंढरी आहे त्याच्यातल्या विठोबाची पूजा करूया असं म्हणून आपण आपल्या पॅनलची सुरुवात करू. This is a very common day-to-day topic for all of us, what clinicians should know about blood and blood transfusion. I welcome all the panelists of this first panel. Today the CME is into 6 panels and each panel will have a clinical correlation or clinical aspects of transfusion. We are really thankful to the IMA dignitaries, President Dr. Meenakshi Deshpande Madam, Honorary Secretary Dr. Alka Shirsagar Madam, IMA Secretary Dr. Geetanjali Sharma Madam. In association with IMA, JANAKALYAN Blood Center has been organizing academic activities in the past as well. We continue the same today with the topic immunohematology and transfusion medicine updates for clinicians. In day-to-day practice, we come across many gray areas where proper decision has to be taken by teamwork. So in aspects to transfusion, bedside practices or decision making, these are the day-to-day queries which come to us. So regarding the same, we would proceed directly with a case. 72-year-old male patient presented with early onset of fatigue and breathlessness on exertion since last 3 to 4 months. There is no history of acute blood loss. On examination, there is severe pallor, no organomegaly. Basic investigations, hemoglobin 6.4, O negative blood group. He is admitted in the general ward with a plan of transfusion for 2 units and further workup. So this is a very common case which many of us come across. I would like to ask first question to Dr. Sathe madam. What is the duration of transfusion when we plan a transfusion? What should be the duration for transfusing 1 unit, especially for red cells? Please, ma'am.
Thank you, Dr. Tanvi, and thank you, Dr. Kulkarni, for organizing this interesting symposium. Actually speaking, transfusion medicine has come of age. There are so many changes since we started learning in our college days. And today, actually coming for this symposium, I had to brush up the NABH criteria because we really have to follow those and everybody has to remember those, okay? So in this case, clinically, if I have to speak, I would not rush for transfusion because the patient is symptomatic for 3 to 4 months. He is not in failure, breathlessness has been increasing. So other clinical parameters we will see. And plus, before giving transfusion, we have to send all the investigations because after giving transfusion, even the peripheral smear changes and we may not get the correct underlying condition, what we are dealing with. But once it is decided to give a packed red cell to this patient, you asked about the duration.
Yes, ma'am.
Once it is issued by the blood bank, it should start transfusing within half an hour and max it should go not more than 4 hours.
Yes.
That is precisely what I would like to say.
Yes, ma'am. Thank you. An additional sub question also. Before transfusing every unit, is there a need of pre-medications? In many places, there is a practice for every transfusion, they do that. So what is the recommendation?
This is very pertinent question. Pre-medications which are considered are like Avil and hydrocortisone, okay, I mean, antihistaminic and steroid, or sometimes even diuretic, okay. So ideally speaking, if there has been good matching and cross-matching, then there is no need to give this. In fact, if you are giving blood transfusion for the first time for that particular patient, it will mask the underlying reaction. So it should not be a routine practice to give it just for you to feel safe. Secondly, about the diuretic. Diuretic will be given only if the patient's ejection fraction is low, heart is not working properly, or patient is already in shock or overloaded. So in that situation only, we will consider a small dose, and it can be given in between also, not necessarily as pre-medication.
Yes, sir.
Sometimes we also give Lasix if there is a very severe anemia, where you feel the patient is on the brink of failure. So that also another indication for that.
Yes.
Otherwise, definitely routine antihistaminics now definitely we don't give.
Yes. Thanks to both of you. We all should remember that each and every transfusion will not require pre-transfusion medications. One more point here, whether injectable drugs, if they also have to be given in the same time, can they be injected inside the blood bag? This is a common query which comes to us many times. So please guide us.
It should never be done like that, because it has to be a completely sterile and aseptic blood transfusion system, whatever we are giving to the patient, because we are actually entering something directly into the bloodstream, and the chances of sepsis, development of sepsis, are very high. Also, we don't know what drug we are injecting that can affect the red blood cells to lyse also, because it may change the osmolarity, it may change the pH of the whole solution.
That's again a point to remember. Yes. Next question, I would request Dr. Khandeval madam to guide us. The rate of transfusion, when we start a red cell unit, what should be the ideal rate to start and how to continue?
So we are supposed to start it slowly, watch for reaction for the first 15 minutes. So that's like 1 to 2 ml per minute for the first 15 minutes. Yeah. And after that, you can increase it up to 4 ml per minute. But again, all of it has to be clinically, you have to see the condition of the patient and then decide on the rates. You have to see the clinical cardiac condition of the patient and then decide.
So hemodynamic status of the patient
Status of the
will definitely
patient,
be a
definitely,
deciding factor.
definitely.
Yes.
If like intraoperative, when we are generally for us, it is intraoperative
Yes.
blood transfusion. When we are giving intraoperatively, we are usually replenishing the blood loss that is already there. So we do not as such need to go slowly until and unless the patient already has a premorbid condition like cardiac disease or a renal disease. In that case, as they said, we will be using a diuretic and then increasing the rate depending on the blood loss.
Yes. Yes. Thank you, madam. Another question to Dr. Melenkeri sir. This patient had O negative group. He was 72-year-old male. So in such patients, would you suggest to transfuse Rh positive red cells?
Yes, that's a very important and very good question. So, if you are O negative and there is an emergency and you don't have O negative blood at all available, then if you can very well transfuse O positive, especially if it's a male and, about the, or somebody who's older, the pregnancy has already been done. So when you are transfused O positive blood, you will develop anti-Rh antibodies. But these typically take about 2 weeks to develop. Okay? They take about 2 weeks to develop. And within that period, you can give any number of positive bloods that you want. Okay, so you're not going to have immediate intravascular hemolysis if you're transfused O, unless the patient already has existing anti-Rh antibodies. That's the situation where you have to be careful. But otherwise, if it's the first unit of blood and it's an emergency, you can very well transfuse positive blood.
Thank you very much, sir. From blood bank perspective, O negative inventory is always a challenge. So when there is a crisis, definitely we can consider this. Similar to negative, even for ABO alternate groups, can you just guide us about that?
Yeah, so all the positive blood groups, I mean the Rh positive patients can receive negative blood. Okay. Somebody who is who's AB can receive A blood or B blood or O blood. So it's a universal recipient. So if the problem is only the O negative patient, O negative is the one who can't receive anything else. You should receive only O negative.
Yes. Thank you, sir. Another common question from certain branches is about fresh blood. They specifically request to give blood from within 5 days of collection, 7 days of collection, or a day of expiry is there on that day. So they are hesitant to transfuse that unit. So could you guide us about that?
Yeah, so that is a very, very unresolved and a very difficult issue. It has been going on since years together, but still there is no clear answer to this. And the reason for that is that good randomized trials to address these issues have been lacking, basically because the heterogeneity of the patients that where the blood has been transfused, etc. So evidence is not very clear. First question is how do you define fresh blood? What day would you truly call as fresh blood? And there's no answer to that also. Okay, whether it's 1 day, whether it's 5 days, 7 days, 10 days, nobody knows. But in general, if you look at the the chemical constitution of the stored blood, in general, it is said that beyond 10 days, it starts to change significantly. So if you really want to call it fresh, maybe the upper limit can be 10 days if you want to call it like that. Okay, but that then again, this is sort of maybe my definition, but somebody else's definition may be different for fresh blood. Truly fresh blood, maybe the patients who may deserve to receive this is one, intrauterine transfusions or preterm neonates. That's it's quite important because stored blood will have certain amount of potassium in that, because of the lysis of some of the red cells, they will have potassium. And very small neonates, they may go into hyperkalemia because of this. And that's why it is important that there you use truly fresh blood. They also said that patients who are recurrently receiving transfusions such as thalassemics and sickle cell anemias, in these patients it is preferable to give fresh blood. And the other indication that there was an NEJM study maybe a decade ago where they said that patients who are undergoing cardiac surgery, their blood which was given less than 10 days old, the patients had a better outcome. So maybe in some of these patients it may be justified. But in general, for any other patient, you can give blood right up to the date of expiry. There's absolutely no problem, no indication. Although there is a change in the constitution of the RBCs, it doesn't really reflect clinically. It doesn't matter, and therefore blood is such a precious commodity that you can't really afford to discard it just because it is a little old. So that it's a very important thing. It's more of a the psyche of the clinicians, especially surgeons. So that we should do away with that myth.
When you are talking about fresh blood, as you said, that in olden times there used to be a question, "Oh, 5 दिन के पहले का है fresh चलेगा क्या?" So that is very funny. So at least you defined 10 days, based on what we still do not know. But what is the pathophysiology underlying? Why fresh blood is important? Because whatever is stored blood, it is when it is given, it will increase volume. But to increase oxygen carrying capacity, it is going to take at least 6 to 8 hours, whether it is done yesterday or 10 days or expiry date. So from my point of view, fresh blood is only the blood carrying capacity. But what else is important? Hemolysis or RBC life, or what is important?
So the oxygen carrying capacity is said to be said to be more in a fresher blood. And the hemolysis is the other issue. If you're going to give multiple units, sometimes the potassium might go up a little bit. That's about it. Nothing else. Nothing else. Yeah, agree.
Yes, thank you. From blood bank and clinical both's perspective, this is very important because inventory management and clinical outcome both have to be taken care of. Thank you for this. I'll quickly just show some charts which we are trying to reach the clinical teams, and displaying some charts at the nursing stations also for alternate blood groups, which is the first choice, which is the second choice. Especially in COVID, we had a lot of challenges with inventory of blood. So during this, the clinical safety of across group transfusions, we have tried to help the clinical teams about this. We'll proceed to the next case. 40-year-old male with an RTA. He was brought unconscious to the casualty at night. There are bruises and contusions on his abdomen, minor injuries on face and arms. Pulse is 60, feeble, BP is 80/50. In urgent USG, it revealed splenic lacerations of grade 4. Patient posted for emergency splenectomy. Due to timely intervention and a transfusion of 31 blood components, this patient was saved. So regarding this critical case, which most of us have come across at least once, so we'll proceed with the massive transfusion protocol, which preparedness from both sides. So Dr. Khandelwal, madam, please guide us about massive, sorry, I would put this to Dr. Prachi Sate, madam, sorry. Ma'am, about massive transfusion protocol, please.
Right. So massive transfusion protocol has saved many lives. Let me just say that since it has started and since it is in place, actually. But this case, which you are talking about, how much is the hemoglobin you said?
That we have not mentioned here, actually, ma'am.
So that is very important. Okay. Now, when this patient is in shock, no doubt about it.
Yes.
When patient is in shock, more than blood, fluid is important. So we have to resuscitate the patient with fluids, because as we said, even after you give blood, 2-3 DPG to get activated, it takes time. So by that time it can come. But most important is 2 large bore needles peripherally and give fluids to improve the circulatory volumes. There are trials which show that rather than blood, if you can actually give fluid to reach whatever oxygen is there in the blood to the periphery, the survival is better. So oxygen carried in the blood is very important in this case. So after that, we will consider giving this. Actually, with fluid resuscitation, one more thing happens, that hematocrit drops further. So hemoglobin, whatever he had on admission, may actually drop further after initial resuscitation. That is also very important. So in this situation, since the time we have, in our hospital, we had established massive transfusion protocol, there is readiness with O negative components like 4 RBCs, 4 compatible FFPs, which can be given to any blood group. So that is plasma of ABO group. AB positive group. AB. And platelets of any unit, any group.
Yes.
So these 4 are kept ready, 4, 4, 4. Okay, there are different types, also different combinations worldwide used, but we are currently using this. And that literally comes within 15 to 20 minutes, it can reach the patient. Okay, and that massive transfusion protocol, we had recently one patient who had massive upper GI bleed, young lady, hemoglobin of 2.8. So obviously this lady required massive transfusion. She was bleeding also, so clotting factors also required. Okay.
Okay, thank you, ma'am. So preparedness from blood center as well as clinical team for massive transfusion, that makes the difference.
Yeah, so junior doctors have to be taught about how to initiate massive transfusion protocol. So there are certain forms, and physically no ward boy goes with the forms. It has to be electronic. It has to be stat informed to blood bank. It has to flash in the blood bank. So everybody gets geared up. And actually it is like a critical care procedure.
Yes. Yeah. Thank you, ma'am. Next one to Dr. Khandelwal, madam. When multiple components are requested from the blood bank, so what should be the sequence of transfusion? Sometimes we receive all of them together. So what would be transfused first?
So first we will start with the PRBCs, the PCVs that have come, followed by the FFPs and then the platelets as required.
So that will be the sequence.
Yes,
Yeah.
and the general, this thing, as madam said, is 1:1:1 ratio.
Yes, yes, right, right.
Or instead of 4 RDPs, 1 HP.
Yes, definitely. Yes. One small sub question about changing of BT sets. There are many queries when we are doing multiple transfusions. So should we continue from the same BT set or we should change after how many units? So could you just tell us about it?
Generally, we are changing with every set.
With every unit, different
we are,
BT
yeah,
set.
because we are getting it, we are changing, because we have no time to assess the
Yes.
reaction if it takes place. Plus, our patient is anesthetized. He's not going to give any physical signs as such. So for us, safer,
Okay.
we are changing with it.
Okay.
I also would kind of agree, but maybe you could probably give about 2 units at least through one blood set if it comes to that. But otherwise, yeah, I mean, generally every blood set comes with a blood
Yes.
bag comes with a set, so
Yes.
you can change.
Okay. Thank you, sir.
About massive transfusion protocol, I would just add one thing, that when there are big tertiary institutes, it is easy to establish it. But then there are so many peripheral units or hospitals who don't have their own blood bank. So the standalone blood banks like JANAKALYAN should have preparedness for massive transfusion protocol for the hospitals in the jurisdiction, certain jurisdiction, where you can reach it within 15-20 minutes.
Definitely, ma'am. I remember one case of aortic rupture, which we had managed like this, and O negative uncross match units we had issued for this case, and really the patient was saved. That preparedness mattered a lot, definitely. Yes, ma'am. Yes. Another common query, especially from the OT or ICUs, whether the unit which is required, which is called for, is yet to be transfused. So where should it be stored? So where should it be kept till it is transfused?
So the platelets will have to be kept out because they cannot be cooled.
Yes.
But the PCVs, at least we can keep in the, we have the fridge in the OT.
Okay. Yes. For red cell units, 2 to 6 degrees is the storage temperature. So definitely if extra unit has been called, it can be kept. But we also suggest to the clinical teams that they should call the blood bank and just confirm. We have found people who have kept RDP units in the refrigerator and then they have asked, what should we do with it now? We are going to transfuse later. So because of not having correct knowledge, many times the resident doctors or nursing teams have placed it in different places. So definitely for platelets, we should not store them in any refrigerated condition. They would get deactivated. So this is one part, definitely. Another about drugs we have covered. So similarly, yes, ma'am.
If it is deferred for some reason, you ask for a unit, but you don't transfuse, then how long it can be kept and should be kept?
It can be kept if provided you kept it in the fridge. It can be technically kept, because in the blood bank also it's going to be kept at the same temperature. But in general, once it's been, it's a important policy that once it's been dispatched, don't keep it for as long as you want. You must finish it within 4 hours.
4 hours is the standard. 4 hours is the
Yes.
standard.
Yes, right. in blood bank, the refrigerators have a continuous monitoring system for temperature. So that makes all the difference. The other refrigerators would not have the monitoring. So definitely for a short time, it is okay, but not for a longer duration. Similar to drugs, even for IV fluids, there is a query that whether when there is a blood component being transfused, should an IV fluid also be transfused parallelly or it should not be done? So what is the recommendation?
If it is required that, that the fluid be given, of course, it can very well be given. I mean, there are so many situations where, the patients are on so many drugs and so many fluids that you can't afford to waste, wait for, 2 to 3 hours for the blood to get over and then you continue. So we can very well give fluids along with it. In fact, sometimes even saline, if the component is very thick sometimes, we've in the past, given NS along with it so that, it can.
From the same three-way we can give that way you're saying, sir?
Yeah. Yeah. Actually, yeah. So what do you do with the, where, have you faced situations where the PCV while being prepared, it's been very thick and it's not flowing properly? Have you received such complaints? And
sometimes it can happen because there will be biological variations. Some donors, blood donors, would have a higher hematocrit, so sometimes it can happen that the viscosity is little higher, but there is sagum or a preservative which is mixed, so hematocrit is adjusted. But one or rarely such cases can happen. We generally defer the bag, we release another unit if such a situation is there. No, I just wanted to confirm whether from the same three-way or the IV fluid and a blood component can be given from the same infusion line.
Yes, it can.
Yes. But when it is...
we do not use ringer lactate at that time. We use only normal saline as the crystalloid.
In any specific reason for...
The lactic acid, you do not want it.
Yes, sir, please. Yes, please.
Actually, normal saline osmolality is not the same. It is hyper.
Hyperviscosity of the red cells sometimes happen because if we collected the blood in double bags, sagum, that is fine because you are diluting that. Yes. If you collect in the double bag, because most of the plasma removed, in that case, hematocrit is supposed to be high. In that situation, you find difficulty because high viscosity, not able to transfuse. So saline we can push, we can dilute, then we can give it. And regarding the using the same line, we usually prefer to give it 2 lines. The patient required, ideally we give for the BT from the one line, and the line we can use for the medications. And there are like fluids, we can get easy go fluids and not mix it. So any normal saline, plasma products like FFP and IVIG, albumin we can give it. Like medications, linger lactate, because they're hyperosmolar. So that's a risk for the hemolysis. So ideally prefer to use different line if we give medications, right? So that more easier, not have any problem for the patients and you're also in the peace.
I would agree with this, that there should be 2 different lines as far as possible, but in emergency, sometimes you cannot have. And if you want to give it for dilution of blood components, then it is a different.
Thank you. Thank you, Dr. R.P. Singh, sir. Thank you, ma'am. Next question to Dr. Melenkeri, sir. Back-to-back transfusions or multiple units. Sometimes there is a concept of warmer, whether blood should be warmed because 2 to 6 degrees storage is for red cell units. So back-to-back, if we are giving, is there a risk of patient going into hypothermia or any?
Yes, there is a risk of hypothermia if you're going to transfuse multiple units rapidly. And in that case, yes, blood warmers are available. Or you can even, water bath at 37 to 38 degrees. You can pre-warm the blood and then infuse it if you're going to give rapid transfusions. Also, the issue of hypercalcemia can sometimes be there, and therefore hypocalcemia, and so you may need to give calcium along with it.
But routinely, otherwise for single transfusions or routine required. Practice, warming is not at all recommended, right,
and surely warming under the blanket, that is to be completely avoided. We used to do it back in Sassoon, but that is to be, that should never be done.
Yes, yes. Thank you for that, sir. This query also was asked to us in one of our hospital training programs. This blanket point was asked to us as well. It should never be recommended, right? Yes. In emergency transfusions, as we discussed about massive transfusion protocol, this cross-matching procedure, which takes quite some time, can we really skip it? Can we ask the blood center to issue without cross-match?
So in case of an emergency, saline cross-match can be done, but at the same time, the Coombs cross-match is also at the back end. It should be completed by the blood bank. So in a saline cross, shall I discuss about the saline cross-match?
Yes, sir. Sure. Yes.
So in a saline cross-match, you are only going to make sure that the ABO is compatible. So generally there won't be a hemolytic transfusion reaction. But in a Coombs cross-match, basically what happens is, let me just explain the concept that anti-APO antibodies, which are naturally occurring in people, through your diet and through a lot of blood, a lot of bacteria, viruses, they all contain A and B like substances, so you get naturally immunized against A and B. And all these antibodies are IgM in nature. Okay, whereas apart from ABO, all the other minor blood group antigens that you have, whether it's MNS, PL, RH, Calcita, Phi, Lutheran, all of these are minor blood group antigens against which you don't have naturally occurring antibodies against these. You will only have antibodies if you're exposed to this blood in the past. And these antibodies that you generate against minor blood group antigens are always IgG in nature. Okay, what's the difference between IgG and IgM attaching to its target? When it's IgM, it will immediately fix complement. And when complement is fixed, the target is lysed on the spot. So if you have ABO mismatch, your RBCs are going to get destroyed in the blood itself, and you're going to have intravascular hemolysis. Whereas if it is IgM in nature, IgG in nature, it will generally not fix complement that avidly, and therefore the red cells are only opsonized by the antibodies, and then they are removed later on, maybe a day later or so, in the reticuloendothelial system. So you don't have intravascular hemolysis generally with these. So it is important that so these IgG antibodies against the minor blood groups you will detect only with a Coombs cross match. So where you actually add on Coombs serum and then you look for smaller, lower titer antibodies, etc. So it is important that you do a Coombs cross match also. Coombs cross match takes time. You often keep wondering, why is the blood bank taking so much time? I'm agitated. I want the blood quickly. Why is it taking like one hour? That's because the incubation, etc., is about 45 minutes to 1 hour. So it takes that much of time for the Coombs cross match to be, because you have to be patient.
Yes, sir. Thank you for that. Some NACO NBDC training slides are there. So I've just taken those slides for just to sum up that routine blood grouping, ABO and RH is done, but in cross match, as sir has said, IgG is involved. So that will be detected only when we do a Coombs cross match. So that TAT or turnaround time, it is worth the wait, because otherwise we would not be able to identify those antibodies just with a simple saline cross match. So this is how a simple only ABO incompatibility can be detected if we are doing a quick saline cross match. And when we are doing a Coombs cross match, that IgG part will be detected here. Everybody in college days, they remember IgG as G for garam. We used to remember that warm antibodies, or they react at 37 and IgM would be cold. So that is the key point in cross matching. Again, the turnaround time, as sir had said, 45 minutes, or with gel cards, it is slightly lesser, but still particular time is required. So when we are not able to spare that much time clinically, then only then we should say that without cross match or saline cross match, we should issue the blood. Yes, ma'am, please.
I would like to understand from you that sometimes blood bank says there is indeterminate group. So for that, what is to be done and what are the tests which are very important, and why that indeterminate group comes?
So indeterminate group is typically in the autoimmune hemolytic anemia as a commonest situation where you have indeterminate group. And the reason for that is that, so supposing you have autoantibodies against, say, I blood group, okay? And so all the red blood cells are already coated with antibodies. So when you try to cross-match the unit, it is going to come as incompatible, because when you add serum, it's going to agglutinate. So and sometimes because the RBCs are so rapidly agglutinated that you may not be able to actually check which blood group it is, because when the already agglutinated RBCs, when you add your when you're trying to do your ABO blood group, they will be agglutinated not because because of the pre-existing antibodies, and that is why you will not be able to clearly define what the blood group is. So this is a typical scenario where you have indeterminate blood group. There you just use O. If you're able to do the RH, if you're able to know whether it's RH or not, or if the patient says in the past that he knows his blood group and he has some evidence that this is a positive blood group, you use positive. Otherwise, you use O negative.
In practice, we face this situation quite sometimes, not very frequently, but it comes definitely. And then there is a big problem what to transfuse. So in such situations, O negative again can be transfused if we don't know. And then there is one condition where, means we are talking about blood transfusions, but there are some conditions where patient will die if you give transfusion, and that is autoimmune hemolytic anemia, either warm or cold. No? So
it's a good question. Good thing you asked this question. As I had told you, so autoimmune hemolytic anemia, you would develop antibodies against one of the red cell antigens, never ABO. It's never against ABO. It's always against one of the minor blood group antigens. And most commonly it is RH or it is against I. So as I told you, if you have antibodies against these minor blood group antigens, if you supposing you transfuse a unit which is so-called incompatible in the blood bank, you will not have intravascular hemolysis because they are IgG antibodies. They will coat the red cells and the red cells will be destroyed. So normally if a red cell lasts in the blood for like 15 days, here it may last for like 2-3 days only. Okay, but intravascular hemolysis will not be there. So you can tide over the crisis with with transfusion. 2-3 days later, the hemoglobin will drop again because the red cells are lysed, in the spleen and liver. There's delayed hemolysis, but that is extravascular hemolysis. So you can always transfuse that so-called incompatible blood. In AIHA, we tell the blood bank, don't waste time in doing too many cross matches. Whatever blood you have, just issue that, because you will never get a compatible unit. And if the patient has got a very low hemoglobin, he will die of anemia. So you can very well transfuse that blood. So if you can do the ABO group, you give that group. If you're unable to do the ABO group because of too much of agglutination, just give O.
In the next panel also, AIHA will be still further elaborated. So we'll all look forward for that as well. Yes. Thank you for the input, sir. We'll proceed to the next case. Yes. 50-year-old female, a known case of CS stomach, hospitalized for chemotherapy, platelet count 20,000. So 6 RDPs were requested. And after transfusion of 2 RDPs, patient developed hypotension and rash all over the body, complaint of itching, hives were developed. So transfusion was stopped immediately. Physician and the blood center were informed, workup was done. Patient settled with Evil and F-colin. Remaining RDP units were not transfused. So this is the case commonly, and many of us have come across. My first question would be to Dr. Sathe madam. How common it is to see transfusion reactions in our day-to-day practice?
When you say transfusion reactions, it's a very big array. It can be drastic, like intravascular hemolysis. So I think what you are describing is a minor kind of reaction, and which is probably because of plasma proteins rather than ABO incompatibility. So these minor type of reactions which happen because of plasma protein are not uncommon, I would say. I can't tell in percentage, I don't know. But this can happen, and that can be tackled with like antihistaminic and a small dose of hydrocortisone. But even if it is a minor reaction, whatever is ongoing blood transfusion or component transfusion has to be stopped. There is no doubt about it. And it has to be sent back to the blood bank for further checking.
If we are sure that the reaction is allergic, it's not going to anaphylactic condition. So is it recommended that we can stop the transfusion till the patient settles and continue the transfusion after the reaction has subsided?
No, I don't think so, because even if there is a minor allergic reaction, still it has got potential to go into further allergic reaction. So same component, at least I wouldn't recommend. What do you say?
I'm not sure what the guidelines are, to be honest with you. If it is something which caused a severe reaction, then definitely not. If it's a very minor allergy which sort of goes away with an antihistaminic and a steroid, then I routinely recommend that you can transfuse it. Of course, monitor very carefully. So most of the times patients, can complete that unit, but I don't know honestly what the guideline is. Please tell us.
Yes. Sir, Hemovigilance Program of India, they are now doing studies about the reactions. We are uploading all reactions anonymously to the Hemovigilance Program of India. That would be covered in NABH session also, but they have given this guideline that if it is clearly FNHTR, that's purely allergic reaction, we are sure of it, then after the patient settles, we can continue the transfusion. But that again, within 4 hours, that red cell unit has to be transfused. That has to be taken care of. It should not delay the total duration of transfusion. So they have given this guideline. At least some units can be saved that way, and the transfusion can be completed.
So FNHTR and allergic reactions both can be, you can complete the same. Yeah, that's what actually we've been following.
Yes. But definitely, if we are suspecting that, as Madam said, it is proceeding to anaphylaxis, then definitely we are not going to continue anything about the transfusion. Another common query is, after the reaction has settled, next transfusion, when should we plan it? 24 hours, or what should be the duration between reaction and next transfusion?
I don't think there's any problem. You can very well give. If it's clinically indicated, of course, you can very well transfer the second unit. It's not necessary that you'll have the same problem with the next unit also. That will be too much of a coincidence.
Yes. No, so my query is, when we are dealing with shock and we need to transfuse, so can we go ahead even if there's a reaction?
Is it that the patient is prone for reaction, so he would develop a reaction to the next unit also, or any reasoning behind that? Not at all. So after the patient settles with the previous reaction, we can proceed with the next transfusion also. Thank you for the inputs, ma'am.
I mean, don't quote me, but there's been a situation where a patient was exsanguinating, a lot of bleeding, and multiple units were given. One of them was actually incompatible also, but nothing happened because the patient was bleeding and all the blood that went in went out.
Great. Next question to Dr. Khandelwal, madam. When should we suspect that patient is going into acute hemolytic reaction? Clinically, what would indicate that?
So you want me to talk under anesthesia? You want me to talk? So clinically in the wards or in the recovery for us, if the blood transfusion is going and there's acute reaction, patient would have a rash, patient would have pain at the site of the IV, patient would have oozing from that site. The urine will become dark colored, or in severe cases proceed to anuria, back pain. These are the general complaints. A febrile reaction may be seen. But all this is masked when the patient is under anesthesia. The only thing that we would have is hypotension, which again would be, with the shock that we are already managing. So confusing. Urine output would be dropping, or a high color.
They call it acute renal shutdown when there is a severe, when a patient of A receives the blood of B. If it is that severe, then acute hemolysis, and that can be, yes, right.
Hemoglobinuria, then leading to anuria.
As you said, when patient is under anesthesia or patient is unconscious, so are there any special signs that we should look for when he's going into a reaction?
Basically, you will be monitoring the urine.
Yes, yes. The IV line, any oozing from IV line, is there any particular importance to that?
It is with the acute hemolytic. Also, you would see the oozing. Also, you would see, because you would be giving massive transfusion, patient may be going into DIC. All of this you have to judge clinically on table where you are.
Yes, right. Yes. And once we understand that patient is going into a reaction, just a clerical quick check on the blood unit and the documents. That is the most important that thing that we have to do, so that we are sure that the right unit has been received. My question to Dr. Melenkeri, sir. Delayed transfusion reactions, you just mentioned during your AIHA remarks. So can you just guide us how to identify these reactions or how to prevent them?
Delayed as in non-hemolytic
immunological or
yeah. So febrile transfusion reactions are the commonest thing that one sees, and the reason for those is generally the white blood cells that are present in the urine, the white cells in the transfused unit of blood that cause these febrile transfusion reactions, and there typically the patient will develop a chill and fever and it can be pretty bad sometimes. They generally, you have to stop the transfusion and then administer paracetamol and antihistaminic. In bad situations, maybe a hydrocortisone, and then generally these subside. If they have not been too bad, then you can very well continue the transfusion reaction, the blood transfusion. Sometimes patients develop an allergic reaction. So this is typically manifests as urticaria, wheals. So these you need this is something which you just cannot prevent. The febrile transfusion reactions you can prevent by giving leukofiltered blood. So there are leukofilters available either at the bedside or at the time of donation in the blood bank itself. You can leukofilter the units, and it is recommended that every unit actually should be leukofiltered because there's these transfusions can be avoided. But allergic reaction is something which is because of the plasma of the donor. And that is something which you can't prevent the plasma from going in. So if you are you develop allergic reaction against one of the plasma proteins, then you will have these wheals. So these are bad for the common delayed reactions that we see. Of course, there are others like TACO, transfusion associated circulatory overload, and a very rare TRALI. Sorry, I forgot TRALI. Sorry. You can't forget TRALI. Yeah. So TRALI is because of antibodies, pre-existing antibodies in the donor against the recipient's leukocytes. Okay, so it's the opposite of febrile transfusion reaction. In FNHTR, it's because of the leukocytes from the donor, whereas here this is because of antibodies in the donor that can react with the leukocytes of the recipient. And to prevent TRALI, in general, so the highest chance of TRALI is with fresh frozen plasma, right? Because you're getting a lot of plasma. In a RBC unit, there's going to be very little plasma, but here in FFP, you have a higher chance. So in general, what we have done is at Dinanath, when I came in, I said no female plasma at all. Because females in general tend to have more antibodies as compared to males. So, yes, multi-parasferon, because they've already been sensitized often. So we avoid giving female plasma in general. And if it happens, so TRALI will typically manifest within the first few hours of the transfusion. Patient typically develops some amount of fever, but predominantly respiratory distress, and it can even progress to severe hypoxia requiring mechanical ventilation for a while. But the outcomes of TRALI are very good, provided you identify it early and differentiate it from other conditions. The outcomes are good. It is mainly just supportive care. Nothing else really helps apart from good, oxygenation.
Thank you. Yes, ma'am. Yes.
So Dr. Melinkeri, since you are here, I would ask all my queries. One means what we have to explain to the relatives. One very important thing is people feel that I have given it for my son and you transfuse that unit to my son. So that is,
Yes, it is there in the next session actually. So we'll be covering it. Yes.
I don't want to break the fun of that Amar Akbar Anthony situation. So, we call it Amar Akbar Anthony.
Yes. So coming back to transfusion reactions, our clinical team has to update the blood bank and send a post-transfusion sample details of the reaction so that the blood bank can work up and give a report about what the reaction was about. This we have covered. So in the end, we are almost towards the end of the session. It was a very interesting discussion about the clinical aspects and day-to-day scenarios of transfusion and clinical team. Also today there is a blood donation camp ongoing in the same premises. So I think the donors, the clinical team, the blood center, all of us together, we are in one team when it comes to saving the patient. We may not be meeting every day, but indirectly we contribute to saving the patient in our own way. So with this note of being in the same team, and so especially because of that, being on the same page, having similar protocols was a very needed thing. So it was a good discussion with all of you. To all respected panelists, I extend my thanks for participating and giving your inputs. We will continue this later as well, even though the panel has been completed. Thank you to the audience, online, offline, both of them. Thank you for listening. Thank you.
Thank you for giving me official opportunity to ask the questions to him. And to Snehal, yesterday I actually talked to her quite a lot, and it is learning for all of us. Thank you.
Thank you, everybody.
Please be seated. It was a very excellent discussion. and think okay, we need this because the experts are experienced experts. So more than 25 years experience, and really when the case comes, then only you know what to do, and otherwise we are just reading in the book. But when the actual case comes, it is the examination of all team. So thank you very much, all the panelists, and Dr. Yardi madam, moderator. Now I request our president madam, Dr. Meenakshi Deshpande madam, to come on the dais, and Dr. Atul Kulkarni sir to come on the dais. We will be felicitating our panelists. Yeah, yes, yeah. Yeah, yeah. Yeah. Dr. Tanvi are the moderator. Call out the name. Yeah. Dr. Prachi Sathe, madam. Every panel is going to be different, so Varani sir can join us. Yeah, sir, yeah, please. Thank you all the panelists. Madam, खूपच छान झालं हे session. So now I request our Assistant Secretary and Joint Treasurer, Dr. Virendra Oswal, to continue.
Good morning, everybody. After a nice start to today's CME, I'm here to introduce you to the speakers and moderator of the second topic. The next topic will be when, what, and how much to transfuse. The moderator for this session is Dr. R.P. Singh, Ravindra Singh. He's specialized in transfusion medicine. He's attached with Aditya Birla Memorial Hospital, Chinchwad, Pune, as a senior consultant and in charge of Department of Transfusion Medicine. He has got more than 20 years of experience in this field. He's a fellow in transfusion science from UK. He's a recipient of Young Scientist Award in the field of transfusion medicine 2015. He has various publications in index journals and reviewer and author of various index journals. I request Dr. Ravindra Singh to please come on the dais. Thank you, sir. The speaker for this topic, what, when, and how much to transfuse, Dr. Mukund Penurkar is a consulting physician and diabetologist in Kothurud and Erindvan area. Is attached to Sanjeevan, Shashwat, and Krishna hospitals and has an experience of almost 20 years in this field. He is a managing director at Sanjeevan Hospital, secretary of API Pune, organizing secretary of upcoming MapCon 2022. He has certified courses in diabetes mellitus, hypertension, advanced course in thyroid disorder management, and HIV medicine. He has been the principal investigator for many global and Indian studies such as endoxaban in DVT. He has been the principal investigator for many global and Indian studies such as endoxaban in DVT. He has worked relentlessly at the forefront during COVID pandemic and was felicitated by the Health Minister, Mr. Rajesh Tope, and respected Devendraji Fadnavis. I request Dr. Mukund Penurkar sir to please come on the dais. Second speaker for this, once again, Dr. Samin Milin Kerige. Sir is a senior hematologist at Dinanath Mangeshkar Hospital with more than 25 years of experience, and he has a special interest in stem cell transplant. Thank you, sir. The last speaker for this talk, Dr. Sachin Yadav. He is on way. He will be reaching here in a couple of minutes only. He's a MD medicine. He works with Chintamani Hospital in the Bibewadi. He's a medical director and physician there. He also has almost 20 years of experience, and he's a past president of Pune Doctors Association. He will be joining us within 2 to 3 minutes. So I request moderator RP Singh sir to take over the session.
Thank you so much for your kind introductions at the outset. I'm thankful to IMA Pune President, Madam Dr. Meenakshi Deshpande, Secretary Dr. Alka Shirsagar, and Dr. Gitanjali Sharma, and Dr. Atul Kulkarni, IMA, and Dr. Yardley for giving the opportunity to come again and have interaction for all a wonderful audience here. And it is always a privilege to have a distinguished our panelists here to we have a discussions. And we try that make this more interactive session. So each and everybody could have like the doubts and it need to be clear. Okay. So transfusion medicine is like always be ever changing field. If you compare the era where like glass bottle used from that time, because this is always be emergency situations and mostly in the war field where the soldiers, they are in danger, we have to give a blood to them. So blood is to collect in the glass bottles and then giving for the patients. And with the invent of plastic bags, so from there the entire shift has changed. And like we can able to make the more component because in the glass bottle we can keep as a whole blood, and there's a limitations for storing for a long period of time. So contamination, because blood is a like good culture media, and that's a risk for bacterial contaminations. We cannot take it for longer distances. So there's a limitations that is overcome by the blood bags, the plastic bags being invented. And in 1950 onwards, that is the invention has done. And from there we start making the components. So component era started from that time. And then with after that we started apheresis machines. So with the apheresis, 80s, late 80s they started. So now we enter into the era of the transplantations and giving a plasma exchange. All is because they evolve gradually. And with the component therapy, now this become like activity, the blood bankers, we can say the transfusion medicine expert. They come together, they are join the hand to manage the patient on the sites. So blood centers and the transfusion medicine field changed in the mid of the 80s. So from where we just evolved, and right from the blood collections to the transplantations, and now we're looking to the future. How? Because until now we don't have a replacement for the red cells. Whatever or the components, whatever we get from the only donors, and we are looking for the how to repopulate. That is the we can say like genetic engineered red cells. Still in the like in the field of clinical trials. So from the stem cell we can repopulate and then we can give it, and n number of quantity we can produce it. But feasibility is not there. Trials are going on all over the world. Even in India, they also try to have like some studies and they try to develop it, but not for like bench level use. And for conventional cross matching and testing to shifting for the molecular testing. So molecular testing is started in India, but only few centers because again, very costly process. So where the problem we face, like compatibility issues, and we are not getting the competitive units for multi-transfusion patient with AIHA. For the molecular testing, we can manage it so that we can able to give a compatible blood for the patient. So now come for the our discussion. So as we, because from the whole blood, we can separate the blood components. We can prepare the plasma. From plasma, depend upon the different program we used to use. We can prepare the fresnel plasma and platelets, or we can prepare the cryoplasma and cryoprecipitates. So mostly we can use red cells, fresnel plasma, platelet concentrates. That could be from the whole blood or apheresis machines. So these are like every for the platelets we can use and cryoprecipitate. So these are the components we use routinely for that. So one by one, we can start from the component which are more commonly required. This is red cells transfusion. And there's mostly a need because the patients are anemic, and even for the critical situations, we required for the transfusion. So with the distinguished panelist, I suppose to ask, Dr. Medin, what is the recommended threshold for the red cells we give for the patients? Yes, yes.
Hello, good morning. I think before coming to directly the threshold, overall in the chronic cases, I think we should, as far as possible, avoid blood transfusion, because many times when it is not needed, many times we have seen a patient of hemoglobin of 5, 6, 7, but that has happened over a period of time. So if the patient has already been compensated for what exactly has happened, if we see that the hemoglobin of a particular patient is around 7.5, some clinicians may think that we have to just go ahead with the blood transfusion because the hemoglobin is on lower side. But mainly if it is a chronic case, in acute cases, it is something different. But in chronic cases, we have to just evaluate as to why the hemoglobin has fallen and how much the patient has compensated, because sometimes or many times the patient doesn't have any symptoms related to it, and that is why the patient has come late to us. We see so many number of patients who have come with hemoglobin of less than 8, but the patient doesn't have any specific symptoms. So the patient has been compensated by our own body mechanisms. So for that particular thing, only for the value of hemoglobin, we should not transfuse. If it is the iron deficiency anemia, then we can try and give injectable ions, or sometimes even oral medicines can also be given. But nowadays we have seen so many injectable iron preparations are available. We can give that particular thing, and we can try to see what exactly is the cause of that iron deficiency. Also, if it is blood loss, then we have to just try and see whether it is malignancy somewhere, especially in the elderly patients. So why I am telling this, because since last 2 years, we may have seen there are not adequate transfusions, adequate blood camps happening. So we are definitely in deficit of blood bags. So it is always better that we should try and avoid transfusion in such cases. Dr. Melin Keri may agree. We have seen so many patients of hemoglobin less than 5 also, and we could manage them without transfusions, even if the hemoglobin is 4.5 or 5 gram, because many patients of such category are megaloblastic anemia, which is very, very, very common in our country. B12 deficiency is very common. We have, in that case, we have to just see the smear of that particular patient. If the MCV is more than 100 and LDH is more than 1000, then we can just consider that this is a megaloblastic anemia. Of course, as I said, the patient should have been a compensated one. So this is a clinical experience. By definition, if you ask me, less than 7 hemoglobin, then we may have to transfuse a particular patient, especially if the patient is decompensated or the patient has other comorbidities, especially in terms of heart failure or some COPD type of condition. So if the patient's cardiopulmonary status is not good, then we may have to transfuse, or by for any reasons the patient has to be admitted for the other reasons like failure, then in those cases we have to transfuse a particular patient. But mainly in other chronic cases, I would say more than 70% of times the patient may not need transfusion. So we have to just evaluate, we have to see what exactly is the cause. But this is altogether a different thing in cases, acute cases. In whenever the patient has come to us with hematemesis or with road traffic accident, in such cases, definitely we may have to transfuse the patient. In that case, again, we may not see what exactly is the hemoglobin of a particular patient. Yesterday only we had a patient who had a massive hematemesis. The history itself was telling that the patient was vomiting blood. They nowadays we can see the photographs of what has happened before the patient has come to us. So patient's relatives take photographs and tell us that this was a particular history of that patient. The patient vomited blood clots. In that case, even if the hemoglobin is more than 9, 10, we have to just see the clinical condition. Patient has tachycardia, the patient has hypotension. In those cases, we may not see what exactly is the hemoglobin, and we have to just go ahead with the blood transfusion even before the reports come. And in case of road traffic accidents also, we know many a times, especially the abdominal trauma, in those cases, splenic trauma and all those cases, we see that the patients are deteriorating fast. We can see the patient has pallor, and in such cases, we have to transfuse without even seeing what exactly is the hemoglobin. So overall, what I wanted to say was we had to see the patient's clinical condition, and then at some times we may have to apply the definitions of what exactly is happening.
Yes, rightly said, because you clearly categorize the patient with acute blood loss and the chronic anemia. The acute blood loss, we have to give it transfusion as per the threshold. Chronic blood loss, because in the India, mostly population, especially female, they are anemic and mostly the nutritional. And those are vegetarian, they are beta and B12 deficiencies. And once we like see the indices clear cut picture, get a picture of which kind of deficiency the patient usually have in a like peripheral smear. And you amazed once we give corrections, immediately the hemoglobin shoot up. So that's the reason, even though like rightly said, in the pandemic area, we have very shortage of red cells. So forcefully we are shifting from bloodless practice. All this indicated now we can minimize the use of blood component. We shift for the bloodless surgeries and other cases. And this situation we can able to give the unnecessary transfusion. We can say which we can correct with the replacement or the bloodless option. We can use it. Whereas indicated acute blood loss, we have to give it as per the indications. So now next come for the Dr. Sachin, why PEG cells is ideal for transfusion compared to whole blood?
So good morning. Sorry for the late. I was stuck up in the emergency with the case of hematemesis only. So it's a nice symposium. So nowadays we are following the evidence-based medicine. So and we have the blood components which are now easily available, especially in the cities like Pune. So PAC cells are definitely used much over the other components of the blood. So PAC cells are the component of the blood from which the plasma and the platelets are removed. So in patients who have already the compromised cardiac conditions, who are already fluid overloaded, like chronic renal failure patients, congestive cardiac failure patients, liver cirrhotic patients. So there, for the symptomatic patients where we have to correct only anemia, so there we can give only the RBCs, which is a PAC cell blood. So that can avoid the fluid overload or the volume overload, which is very much indicated in such patient. Second, the most of the reactions are because of the plasma, which contains the plasma proteins, which are the antigenic. So that can also be reduced. I won't say avoided, but that can be reduced if we use the PAC cell volume. And second, we can use even the wash RBCs or even the leukodepleted PAC cells, which can reduce the blood-related reactions. Third thing, the Whole blood is indicated in some patients where we require the plasma as well as we require the platelets. So the indications are very few nowadays. And third thing is we can use the ABO compatible blood in patients where we require the pack cells. So that is one of the indications, because nowadays we are facing the shortage of blood. So components of the blood can be used which are compatible. So that these are the indications for using the pack cells.
You rightly said, because nowadays we use pack cells. The pack cells will reduce the volume overload, so we can give like multiple unit. The patient is really anemic. So instead of we could whole blood give 1 unit, pack cells we give 2 units. So we can correct with the lesser volume. And then again, rightly said, because we can give options for the compatible. If we're giving a whole blood, only 1 unit can give. Like suppose group is A, so we can give A because plasma is there. And if you give pack cells, we can give A and we can give O. So that is options be available and inventory is less. The patient can manage in the better way. So now next questions to Samir sir. We had need to know about your experience of liquid depleted blood and which patients you would prefer them to give that.
We are trying to move towards universal leukodepletion. The only problem with universal leukodepletion is the cost that, already there's a hue and cry about cost of blood going up. So when you use filters and remove the cost of the blood is going to go up a little more. Otherwise, ideally, you don't need the white blood cells in any component, and you just need to remove it, and therefore all blood should ideally be leukodepleted. But in particular, the patients that I treat, those who are receiving recurrent transfusions. So, removing the leukodepletion will help in terms of, one, preventing febrile transfusion reactions. Second, to prevent alloimmunization, which is important, for patients who are requiring recurrent transfusions or those who are going to undergo bone marrow transplants. And thirdly, CMV infections, certain viral infections which are transmitted through the leukocytes like CMV, that can be prevented. These are by and far the three most important. There are some other minor ones, but these are the three main sort of advantages of leukodepleting blood. So there are two ways of leukodepleting blood. One is, so you get a filter which has a chemical, which has a membrane on it, which sort of chemically adsorbs the leukocytes. It doesn't remove the leukocytes by filtration. It just adsorbs these leukocytes, and therefore the rest of the blood passes through it. So you have filters which can be given at the bedside. So instead of the blood bag, which you normally use, you can use the filter. It has a filter, then there's a specific way in which you're supposed to, fill up that filter. It's simple. And then you transfuse that unit of blood. The other way, so there are different filters for RBCs and different for platelets. What we now do is at source leukodepletion. So when the unit is collected in the blood bank itself, the RBCs, the components are leukodepleted, and that's what we do. So it is very, very comfortable to transfuse the leukodepleted blood because it will not cause a fever. Or the patient is already running fever because of some other reason. Then you often have to wait till the fever goes away, give paracetamol, and then transfuse the unit of blood. But if you have a leukofiltered blood, even with the fever going on, you can still transfuse that blood.
Right, sir. So that's your recommendation. If permit, we can adopt a universal leukodepletion. But cost is a factor in India because we are not like the sponsor as overseas and developed world they have. So actually, they have a liberty. We don't have a liberty for that.
If we think, if all of us can get together and, decide that we want leukodepleted blood, and then we can squeeze the companies and, make them reduce the cost so that it becomes cheaper for everybody. I think we have to get together in this.
Yes, the petition pura dal dete hain. Good, sir. Right, sir. So now next, we move for the next most critical compound, that is platelets. After the red cells, that is the most commonly required for the transfusion. Samir sir, again for you, what are the indications for platelet transfusion?
So for platelet transfusion, there are it's a gray area. What should be the platelet cutoff? So in general, any platelet count of more than 50,000 is generally sufficient for surgical hemostasis. So any surgery can be done except if it is a neurosurgery or a delicate retinal surgery or a delicate plastic surgery where a little amount of bleeding can cause a disaster. There you want to keep the platelet cutoff of 1 lakh. for neurosurgeries, but otherwise 50,000 is sufficient for any abdominal surgeries. For giving spinal anesthesia or epidural, they say that about 70,000 should be your cutoff. That is, who decided that? I don't know. The anesthetists got together probably and decided that, but that is what they tell us. Otherwise, your spontaneous bleeding will only happen if the platelet count is generally below 20,000 or maybe 30,000. Below, above that, you will not have spontaneous bleeding. So when we are giving chemotherapy, that's a typical scenario where a lot of platelets are required. There we keep a cutoff of about anywhere between 10 to 20,000 as a cutoff for transfusing platelets. In somebody who is, who's used to having a low platelet count, say in a ITP, or a very stable sort of bone marrow failure, where the body sort of got used to living with low platelets and they don't bleed at any platelet count. There we sometimes keep a cutoff as low as 5,000. In ITP, of course, we don't transfuse at all. We transfuse only if the patient is actually bleeding.
So surgical, you recommend the 50,000 cutoff, except the critical sites, the eye and brain surgery, we can keep 1 lakh. And any of the hematoma patients, they require 10,000, 20,000, depending upon the situation. Even for the plastic hernia, we can wait for 5,000 as well. So next questions to Dr. Mukund. What is the threshold for the platelets? Because already
I think Dr. Samir Melinkeri has already answered.
discussed.
But I would add to
Yes, please.
what he has said, especially in cases of dengue, which we see in this season. Many a times what happens is it is the pressure from the relatives or the patient, or sometimes the general practitioners who may not have adequate experience or knowledge, or sometimes we have to consider the legal things that I think I would ask Dr. Melinkeri also, because many a times what we see is even the platelet count, even if the platelet count is less than 10,000, the patient doesn't bleed or patient doesn't have anything. Maybe 2-3 days we see that the patient's platelet count is less than 10,000. Some times in India, especially in our setting, we see that the patient may not be affording sometimes. And in spite of telling or in spite of recommending that we have to transfuse the patient, if the platelet count is less than 10,000, the patients do not transfuse. In those cases also we have seen that patients don't bleed or there is no issue at all. I think there is something more than only a platelet count that needs to be seen, whether we have to transfuse a particular patient or not. But of course, by definition, if the platelet count is less than 10,000, then we may have to transfuse, except in cases of ITP. And otherwise, we have seen patients bleeding at the counts of 70, 80,000 also. I would tell one case last year only, which has happened to us. The patient was admitted with dengue, and patient's platelet count initially was around less than 10,000. So we transfused the patient with RDPs. And thereafter, the patient's platelet count improved. Everything was okay. After 4 or 5 days, the patient's platelet count was 72,000. And we were just discharging that particular patient on that day because the platelet count was all okay. And also the patient's clinical condition had improved. But I got a call from the resident that, sir, the patient has become suddenly unconscious. In that, we just saw the CT, the patient had a large IC bleed. The patient was having dengue. In spite of transfusions and in spite of the platelet count being 72,000, the patient had a large IC bleed. The patient was having BP of around 160/90. It was not too high also. But there are some definitely mechanisms which cause the bleeding apart from only the count. I think Dr. Melinkeri can elaborate
Actually,
on that.
we have one case discussion. So this point we discuss in the case. So, but we keep for case-oriented discussion because these things will cover in that way. So next question, because now we are talk about the indications and the threshold. And Dr. Samir, we can ask one thing, because if you give options to get a single donor platelets and random donor platelets, so which we will prefer?
I have to think. Yeah, so I have to think only because I don't bother too much about this nowadays. Of course, if it is going to be a one-time procedure, or the patient is not going to require frequent platelet transfusions, then SDP is obviously better because you're going to give a single donor exposure. So definitely that would be better. If you ask me what I would do for my acute myeloid leukemia patients who are going to require so many platelet transfusions, then it doesn't really matter. Right. Sometimes if the patient is actually alloimmunized, I don't know if this is a little theoretical, but maybe you can guide me. But if the patient is already alloimmunized against platelets, then if you give a single donor platelet and the patient is by chance alloimmunized to those platelets, he won't have any increment at all. But if you give random donor platelets out of those 4 or 5 donors that you've given, he might be sensitive to one, and he may be not sensitized to one. So you may get some sort of an improvement with the RDPs.
Yes, sir. In that situation, RDPs are preferred because you rightly said there's like antiplatelet antibodies. If you're giving like pool off, so we can able to get a compatible in. If you can be like in a single donor platelet, there's one indication we can say we prefer the RDPs. But if you can say reduce the exposure, SDP is always we prefer, and then we can like reduce the exposure and give a more safer component to the patient. And depending on the condition of the patient, yes, patient to patient we can judge. So that is all depending on the condition. How can you judge it? But benefit wise, SDP is benefit because we always prefer to give SDP for our patients. Only RDP key for is a 4 as an emergency protocol. So this is our protocol we used to follow. Now with the indications, we have to know what are the like contraindications of the platelets. Dr. Sachin, we can ask.
The contraindications for the platelet transfusion are very specific. The patients who do not have the bleeding manifestation and platelet count more than 10,000, that is, I would say we can save the platelets. Second indications, the patients who are having the thrombotic thrombocytopenic purpura, where platelet transfusion will aggravate the condition, and the treatment of choice in such condition is either plasmapheresis or the IVIG. And second is the heparin-induced thrombocytopenia, which is very common with the regular heparin as compared to the low molecular weight heparin, where platelet antibodies will destruct the platelets. So that is also one of the contraindication. And third contraindication is the post-transfusion purpura. So there also we cannot give the platelets. So these are the 3 contraindications for the platelet transfusion.
It's rightly said, because ITP, the situations, if you're seeing only platelet, they start giving the transfusion. And that's what be adding the like food into the fire. The patient very well set as the even low count. If the count is 2,000, 3,000, the patient very well managed. Only plasma exchange and IV is a like treatment of choice. So we can able to manage and recover the conditions. So this is all about the platelets. Now we come for the another component, transfusion plasma. So the question is to Dr. Sachin, what are the current recommendation for uses of transfusion plasma?
So fresh frozen plasma are indicated where we require the coagulation factors. So patients who are having the coagulopathy, the coagulation factor deficiency like factor 8, where we do not have the cryoprecipitates or the specific factor concentrates. So there we can give the FFP. Second, the reversal of the warfarin. If the patient is having bleeding and where the vitamin K takes time for its action. So vitamin K usually takes 24 to 36 hours for its action. And patients who are having the coagulopathy because of warfarin, patients who are taking warfarin for the wall replacement or the DVT. So there we require the FFP for the urgent reversal of the coagulopathy.
Yes, very nicely said. And the patient with the like a massive transfusion protocol is a part of the protocol. We can use that.
So for massive transfusion, we give in the ratio of 1:1. So one Paxil, one FFP, and one platelet. So that is for the massive transfusion. That is the protocol.
Yes, platelet and single donor platelet we can give, or 4 RDP. We can say. Rightly said. So next question to Dr. Mukund. In FFP, do we need to consider RH factor?
I don't think we have to, because in FFP we can give either RH negative or positive, either of these. So we don't need to test or we don't need to bother about what exactly is the RH group of a particular patient.
Yes, rightly said, because RH antigen express no red cells, and these are acellular component. So plasma doesn't have any antigens. So that's the reason only ABO, because anti-BP antibodies are there. So we compare ABO compatibility. But as per the Drugs and Cosmetic Rules and Act, we have to mention RS factor. Otherwise, in overseas, they don't mention because they only mention ABO group. But we have to mention as per the law, but no need to bother about whether the patient is RS positive or RS negative. Only we consider ABO blood group. Dr. Samir sir, do we need to stick to same blood group in FFP transfusion, or we can able to switch some other?
It should be group specific. It is said that in an emergency you can transfuse up to 2 or 3 units of FFPs without, but that's a very rare situation where you actually would need such a thing. You would want to give group specific FFPs.
Right. Normally, with the frozen plasma have a longer life, so we can store it 1 year. So inventory is not an issue except AB group. So nowadays we have more AB incompatible transplantations. So this is the one thing hit at very, because in the situation we AB FFP is to required.
Sorry. So when I meant that, AB is the universal
Yes.
group for this thing. So you can give AB plasma to anybody. So if it's an O and you don't have O in your inventory, you can very well give AB.
Yes, yes. Yeah. So that we can give other, because only rare situation we have to switch over to the, because sometimes we don't have it at the patient, the trauma situation. And in the hospital and more trauma cases, there they have a real requirement, or we are going exchange transfusion for the AB incompatible transplantation. So they have required more of requirement with the FFP. So we can switch over to, because group compatible with the options we have, because for O we can become reverse. For O we can give any group. We can give O, we can give A, we can give B, and AB become last, because that is rare inventory and quantity is very less. So we keep as a precious unit, just like O negative, here is the AB. So that's the reason we reserve AB for the only specific patient. Otherwise, we can able to give for other options. But normally we don't have any problem with the FFP in per se for transfusion. We don't have any much shortage. So another is the very critical component, cryoprecipitate. So Dr. Sachin, what are indications for cryoprecipitates for the transfusion?
The indications for the cryoprecipitates nowadays are the patients who have the fibrinogen level less than 100 with bleeding, or patients who are planned for the surgery. Then second, obstetric patients who are in DIC. So there these cryoprecipitates are indicated. Then abnormal fibrinogen, there also these cryoprecipitates are indicated. And last is the patients with factor 13 deficiency and the one Willebrand deficiency with bleeding, or those patients who are planned for the surgery. So there usually the 1 unit of these cryoprecipitates gives more than 80 units of the factor 8 and more than 250 milligram of the fibrinogen. So the dose is usually the 1 unit per 10 kg, that is the dose. So 7 to 8 for the patient of 70 to 80 kg. So that is the dose of the cryoprecipitate.
Yeah,
and that is
said.
now easily available in Pune.
Yes, yes, yes. So rightly said, because we can easily assume the dose. So we can pay per unit per 10 kg. Accordingly, we can know the weight of the patient, number of unit we can give to the patient. So next question to Dr. Mukund. Do we need to give cryoprecipitate blood specific?
I think again, in cryo, it is not needed that we have to see a particular blood group, because the volume is so less that we can transfuse without having without a particular particular blood group, either with ABO or RH. So we can give any blood group cryoprecipitate, because most of the times it is there are very specific indications, and many a times it is an emergency. So we can just give without any blood group specific cryoprecipitate.
Rightly said, because very less plasma is there. 1 unit hardly contain 5 ml, 10 ml. So if we give 10 units, doesn't have any issues for giving. So we don't need to bother about the AB blood group, right? So this is all about the component discussions. Now we can switch over to the case discussions. There is a 25-year-old girl presented with the emergency department with a fever, headache, abdominal pain, vomiting, and yellowish discoloration on eye for last 5 days. Physical examinations mark pallor, fever, tachycardia, and tachypnea and the icterus, and there is no lymphadenopathy, edema, rash, and petechial on the bruises. Cardiovascular examination reveals 3/6 systolic murmur along the left side and soft spin 3 cm below the left costal margin. Automated cell count peripheral smear normal total leukocyte counts with a normal differentiation or normal platelet count. But in the hemogram, you can say 3 gram hemoglobin only for the patients, and evidence of macrocytosis. MCB is 128, and increase MCH and MCHC. And peripheral smear, that is a gross agglutinations we have noticed in the smear. And direct count is strongly positive, raised, and urine acid is normal. So this is the case of typically autohemolytic anemia. Now we discussed with Samir sir, what are the challenges you feel as a treating physician for this AIHA?
Well, the challenges are, are often seen. They relate to the degree of the anemia, because the anemia can be very rapid, and patients are very symptomatic. And the main issue is that when you ask for a unit to be transfused, the blood bank will find it as an incompatible unit. So, and then the issues of the clinician accepting that unit and the blood bank refusing to give that unit. This is the usual challenge. The challenge is no longer there in the place where I work or a hematologist works, but the problem is rampant when it's maybe a physician working, or the blood bank is not tuned to handling such cases. There it becomes a big problem. I'm sure JANAKALYAN must be facing this too much, because they cater to a lot of hospitals, and they must be having this problem a lot. So now probably the blood bank knows that this is an incompatible unit, and they know that this unit can be transfused, but the clinician has to actually accept it. So if the patient is symptomatic for anemia, if as much as possible you avoid the blood transfusion. Steroids will take about 3 to 4 days to work. So then the hemoglobin is actually going to go up later on. But for that period, if the patient really needs to be transfused, you can very well issue an incompatible unit. What we tell the blood bank is, when you're cross-matching it, just make sure that there is no, in the test tube, there is no lysis in the supernate. So if it is a complement fixing antibody and there is immediate immediate hemolysis of the red cells, you're going to get a hemolysis in the supernate. In that case, avoid issuing that unit. But if it's only agglutination, that means the immunoglobulin has just made the RBCs to come close together, then that unit can very well be issued. So we don't worry too much now about transfusing these so-called incompatible units.
So this is the biggest challenge for transfusion medicine. So the major work is come for them to give a workup. And because if you differentiate between cold and warm, so cold, they can create a problem with the blood grouping. And if it is like low thermal amplitude, it's reacting at room temperature, doesn't have any problem, because IgM then, because they're not taking 37 degrees centigrade. And with the warm technique and then modulation for the process, we can able to identify the correct blood group. And we are testing for the 37 degrees centigrade IgG. If incompatible, there is no issue for the patient regarding the, we can say cold antibodies are there. Except high thermal amplitude, if that is more than 1024, then we can situation we have to see the hemolysis there is not. And the real challenge, grouping is not an issue in the warm, only find a compatibility issue. So for them, because the center, those have hematologists, they're very good tuning, so they understand each other very well. The case immediately come, immediately notify, because the situation now what to do, because see the condition, patient is symptomatic, we can give 1 unit. Very cautiously, okay, 1 unit we can give. Meantime, they're giving a steroid, so take a 2 or 3 days to get effect, and then by the meantime, patient is stabilized. And where doesn't have a facility and vicinity, then there will be a challenge for them. So that is the things. If a patient with IHA, better to get the second opinion with a hematologist, or the centers to have a facility, have a transfusion medicine blood center, so they can consult and then accordingly they can guide it. So in that way, the patient can get a better treatment and without any delay. So patient can able to manage it. We cannot keep it prolonging the critical patient. The patient hemoglobin is 2 and then reducing further, and you are holding the transfusion. So there's no means for holding transfusion, because you have to give it once we need to give it, and we have to hold it when within a required. And the patient hemoglobin is going 8 gram. Patient AIHA, then why we give it transfusion? So this fine tuning and understanding required when we interact each other very well. So this is all about for challenges. And then Dr. Mukund, how you decide to when to transfuse for PEG cell. because this is already, I think
we have already
discussed.
discussed both the next questions. As Dr. Mary said, we have to just wait till that particular hemolytic process is stopped or not over a period of maybe 2-3 days. We can wait, and if it is necessary or the patient is going into failure, requiring oxygen or requiring ICU, in those cases, then we can transfuse the incompatible blood also.
Right. Even the next question, incompatible, that is already have taken care. So we don't bother about the incompatible in this case. So we can keep it because as the patient is required. And that is right to say there's extravascular hemolysis, don't have any problem to be like immediate hemolysis, which is in case of AV incompatibility. Even give a transfusion, they can survive a few days. So that will be taken care for the acute condition. Now, in the second case, 38-year-old admitted in MICU with a complete generalized body ache, the high fever, highest recorded 39.40 centigrade for 3 days. On physical examination, found to be conscious, dehydrated, and heart rate 100 per minute, and blood pressure is low, 100/60. There is no rash or active bleeding. On general system examinations, there is no abnormality work diagnosis. There, basically the case of dengue hemorrhagic fever, they diagnosed. They find there is a pleural effusion for there. Gallbladder edema and the free fluid in the hepatorenal pouch. And after that, they also identify there is a left thigh pain. And in the US, they find there is a psoas bleeding. They have identified the patient. These are the parameters: hemoglobin 13.2, total leukocyte count normal, platelet count 5,000, and marginally raised hepatic enzyme, C-reactive proteins little raised, and PTPT again deranged. The case is clearly diagnosed dengue hemorrhagic fever. So now the pictures come because Dr. Mukund, what component in this patient may require for transfusion? You see.
In this particular patient, as we discussed, the platelet count, platelet transfusion is definitely needed because the patient has already got hematoma and the platelet count is less than 10,000. It is only 5,000. So platelet count, RDPs or SDP, whatever is available. But in this case, we can transfuse the patient with RDPs also. So as I was discussing, there are very specific indications for platelet transfusion. This case is definitely there for transfusion of platelets. And FFP also may be required because I think PT, the coagulation difficulty is also there. So in this particular patient, FFP also is required. But of course, blood transfusion.
This case similar to your case.
Yes.
Similar picture.
Right.
The patient have IC bleed, they have like psoas hematoma.
Right. So that particular case, what I was discussing was, it is not only the platelet count which matters. So apart from platelets, there are many other things which we need to see. And in that particular patient, initially the PTINR and APTT also was normal. But when we saw that the patient has got already the hematoma, IC bleed, we can say, in that patient, both the things were deranged over a period, and then we had to transfuse everything. Samir?
Funnily, I don't know what the mechanism is. Many pathology and dengue are still a little unclear. But what you described about the IC bleed happening when the platelet count had improved, I've seen 3 patients where I was involved where the same thing has happened. When the platelet counts are absolutely low, nothing happens. When the patient is recovering, the platelet counts are actually crossed 30,000-40,000. They actually bled. Maybe that is because during that viremic phase, some internal damages, endothelial damages probably happened in the capillaries of that patient, and that's why subsequently something happened because of which, whether the hypertensive surge or whatever, that actually caused bleeding. 3 patients have seen the same thing. So that still does not mean that we should transfuse every platelet, every dengue with a low platelet count. And even in the national guidelines for management of dengue infection, it is clearly mentioned that platelet transfusions do not help. So I think legally also we might be safe, but I wish there was somebody who can comment on that, because this is a really a big issue which we keep facing. It's more of social pressure, because of which platelets are given rather than any medical indication.
Right, sir, because once the patients start recovering, there's a procoagulant state is there. So that's the reason like coagulation pathway is activated. They consume. That's the reason in this case, you find the PTPT and is deranged. And if you're seeing only for the platelet count and the patient is recovered, So one thing we can bother about, we can see the coagulation profile as well. Along with the hemogram, we can do the coagulation profile. So we can give an initial picture of the patient may be required for a fresh plasma transfusion or not. This is recommended or not for the hemogram. We can go for the coagulation profile as well. So the safeguard initially, because these kind of picture can be identified initially, we can able to manage it. That could be the probability because the pro-coagulation condition for the virus is this.
In a patient like this, where you, especially if somebody has got dengue hepatitis,
yes,
there you must check
exactly
at least daily. You must check.
Yes. For especially dengue cases, we have to do it. So now we come for the third very unusual case discuss. So 50-year-old immunocompetent female had gone to vaginal hysterectomy, and 15 days ahead, she received a 2 unit of blood transfusion. And after the surgery, the went well, and then 4 days later, she developed the picture of edematous passage. And instead of going into details, she developed the graft versus host disease. This is the picture. And because the immunocompetent female, they received an unrelated blood transfusion. So not usually happen very routine. Unfortunately, the patient died, and then biopsy find this skin biopsy, septic shock is there, patient pedic EDS developed. And bone marrow ectophin biopsy reveals cellular marrow, adequate megakaryocyte, and decrease hematopoiesis and increase macrophage activity in the bone marrow. In skin biopsy, the epidermal skin shows the scattered necrotic keratinocytes and all the label lymphocytes, exocytosis, and patches of pericardocytes. And there's a case of grade 2 acute graft versus host disease. So now question is this: what is TA-GVHD and how we can prevent this?
Okay, so there's a very important thing which everybody must know. It's very rare, but the mortality of TA-GVHD is over 90%, and that's why you must all know what it is. So, when you're transfusing any unit of blood, the only white cells that are live in that unit are the lymphocytes. Everything else is dead. Okay, RBCs, of course, and the lymphocytes. So normally, when an immunocompetent patient is transfused with a unit of blood, whatever lymphocytes are there in that unit of blood, they will try to attack the recipient's lymphocytes, and it's always a war between the lymphocytes, right? Because the recipient's lymphocytes are far more in number than the small unit of amount of lymphocytes in the transfused unit of blood. The recipient will destroy all those lymphocytes, right? They will recognize this is different HLA and they will immediately destroy those lymphocytes. But if you have a situation where the recipient's lymphocytes are so badly depleted or so badly dysfunctional that even the small amount of units lymphocytes in the transfused unit of blood can destroy his existing lymphocytes, then the donor's lymphocytes are going to start attacking all his blood components. They're going to enter the marrow. They will cause pancytopenia. They will destroy everything. And then they will clonally proliferate looking at the different HLA antigens in the patient's body and start attacking the body. And the commonest organs against which this attack is, it's called graft versus host disease. They are against the intestine, the skin, and the liver. And these organs become dysfunctional. The entire bone marrow is wiped out. All the cells in the bone marrow are destroyed. And therefore, you'll have pancytopenia with only some lymphocytes of the donor which have engrafted inside the marrow. So your case is a little odd that the patient had a cellular marrow and he died of GVHD. Most of the time, it should be a hypocellular marrow because the lymphocytes have destroyed all the blood components of the recipient. Right? So when does this happen? This happens in patients with allogeneic bone marrow transplant. It can happen in patients who have received purine nucleoside analogs of fludarabine, cladribine. These are some chemotherapy drugs which can cause profound lymphopenia. Hodgkin's lymphoma. In Hodgkin's lymphoma, the lymphocytes are good in number but extremely dysfunctional. That's another important indication. Then severe T cell congenital immunodeficiencies. Okay, so HIV, not a problem because only CD4 is low, CD8 is very good. Aplastic anemia, no problem because it's an autoimmune disease. So T lymphocytes, it's a T lymphocyte mediated disease. Whereas in patients who have SCIDs, etc., where the T cell lymphocytes are extremely depleted, they are patients who are at risk of transfusion-associated GVHD. And there's another case scenario in which this can happen. Okay, that is a patient who has received a related unit of blood. So supposing a first-degree relative has donated blood to that patient. It may so happen that there may be some common haplotypes, which the recipient sees as half the HLA is matched. So the recipient may not reject that HLA, Whereas the reverse may happen, that the donors actually might recognize that, okay, it comes in the body and then it realizes, okay, this is dissimilar actually, and then they can attack you, and then you can have TAGVHD. So if it's a first degree relative, then you must irradiate that blood. So irradiation is the only way in which you can currently prevent TAGVHD. And so all related blood units should also be irradiated. So these are the situations where you can have transfusion associated GVHD.
Right, you said. Dr. Mukund question is already answered. So now,
I'm sorry.
no, sir, that is good, because in the discussion, madam asked a question because the patient relative, they come in fighting because my blood, my patient. So this kind of thing, why we avoid? This is the reason. They say directly say, if you give your blood to the patient, you are going to kill your patient, because you are giving a blood that is patient supposed to die. More than 90% mortality in this case. So if you want to die the patient because of your blood, you can give it. So we have to counsel that.
As I had mentioned, we call it as the Amar Akbar Anthony. Yes, if you have seen Amar Akbar Anthony,
yes,
there is a situation where the three sons have donated blood to their mother. The blood comes into one unit, and retrograde that blood goes into the mother. So to tell you the truth, it's
this is against the gravity.
Against the gravity,
going up,
it goes up.
going down.
but people, when Manmohan Desai made this movie, people had told him that this is a rubbish. Anybody can understand this is completely unscientific. People are going to rubbish you. But Manmohan Desai was sure that no, this scene must come. And truly, when that scene came, it was created this thing. People got very emotional. That scene was a hit.
Yes.
So it means that you can imagine how emotional we actually are. Without understanding logic, we don't know so we have to really explain it to them that, this is what can happen. And that is why it's contraindicated. Or you can transfuse in certain situations, but you must irradiate that blood.
Yes. If somebody is really insists, nahi, hame karna hi hai, to theek hai, then irradiation karke. But usually discourage them, because this practice should not be like flourish and then again have like a bed. Because irradiations especially available only few centers. Right. Not every center they have irradiations. Even we don't have them, we take the facility of JANAKALYAN. So this is time taking. Even the patient is critical situation, you cannot wait for.
Yeah, you can also irradiate in the radiation therapy unit.
Yes,
if you don't have an irradiator.
Yeah, but need to like validate, and then this is like whole things is required. The X-ray radiation is there option, but gamma, that is most preferred. That's why we used to use that.
Yeah. Later on, when pathogen inactivation system comes.
Yes.
The chemicals which you add into the pathogen inactivation, they will destroy any nucleic acid.
Yes.
And therefore, viruses, bacteria, and lymphocytes nucleus will be destroyed. And therefore, TAGVHD can be prevented when you get pathogen inactivation.
Yes,
that is the future of.
In addition, for the risk for unknown viruses, it can alleviate the risk for TAGVHD, because that can like molecules has to be like deactivated in the situation. Again, resistant dream, cost is high, and few cent.
It's a matter of time once it becomes generic.
Yeah, it is there in India. Like a few companies they are like came. One is Ceres and one is like Thermo Penpal. They have come up with pathogen activation. But again, that the cost is a factor, because it's used to work out and it goes for like a rocket really high, and then affordability again the issue. So most cheapest option is the radiation, so that we can give for. Others are very good options, because we can give two benefit. One is the unknown viruses we can inactivate, because we're not testing each and every virus. There's only 3 viruses we used to test, and unknown pathogen can like deactivate. Secondly, for the this TAGVHD we can be taken care. But we hope it can come in the affordable cost in few years. So next is Dr. Sachin. What component we need to irradiate?
The irradiation of whole blood is required. Then the Paxil RBCs, platelets, and the granulocytes, they are to be irradiated. Then second, cryoprecipitates and the FFP, they are not require the irradiation.
Rightly said, because those are the acellular blood component. We frozen at -40, -80 degrees centigrade. In that situation, these T lymphocytes become inactivated. And without any looking for the irradiation, we can give without fear of TAGVHD. None of the cases until now is like identified as TAGVHD because the acellular blood component. So FFP, cryo, we can give without irradiation. Those are cellular blood component. Definitely, we have to irradiate and then give to the patients.
One more question, actually, we miss the transfusion policies in the dengue because dengue is very rampant in Pune. So regarding the PCV transfusion, then FFP also. So only thing we are looking at the platelets, we usually don't look at the coagulopathy. I'm doing the prothrombin time and PTTK in almost every patient on third or fourth day, and we're getting a lot of derangement of this coagulation parameters, and that could be one of the reason the patient might get the bleeding at unusual sites. So that is one of the reason, and there we may require the transfusion of FFP, PT or PTTK is more than twice of the normal. So that is one. And even we are doing the ferritin, which we were doing in the COVID situation. Even D-dimer is also one of the marker for the severity of the dengue. I would say if you can follow this ferritin, D-dimer and the PT-PTTK in the management of dengue, especially in the critical phase of dengue from 4 to 7 days, it would help in the management.
Exactly. That's the reason we recommend we should go ahead for the coagulation field testing along with the hemogram. So that's the reason you can idea, and we can prevent the bleeding tendencies because of not for the platelet, because of the coagulation factor deficiency. So this is all about the today's panel discussions. Any questions with the panelist?
Yeah, that's right. Yeah.
In this SDP and RDPs, these pooled platelets, what is your experience with pooled platelets?
Yeah. So pooling of platelets, what we do is whenever there's a blood camp and there are we pool similar group platelets. So A, O, B. So you'll have. So I mean, we know that RDPs need not be group specific. It is recommended SDPs are group specific. So ABO antigens are expressed very little on the platelets, but they are expressed. So as much as possible, you should give, if possible, you should give group matched platelets. They may last a little longer. So that's the idea of doing, instead of the nurse pooling, giving platelets one after the other, the blood bank does it in a much more aseptic manner. They do it in the blood bank. So 4 units of RDPs are pooled, and that is issued. They are filtered also, and they're issued. So it is a little expensive, but for my patients, it is very useful.
Yes, I have a comment on that regarding we are talking about the SDP. Why SDP? Reason behind, nowadays we collect the single donor platelet, we adding the platelet additive solutions. So in the past solution, we removed 70% of the plasma. So 30% of plasma is there to just keep the platelets active till 5 days. So there is no need to bother about the ABO group for the SDPs. So this is one part.
Right.
Second, again, if you're going for the random donor platelets, again, we're giving a ABO incompatible. Because if you're pulling the other group, they're like antigens are there, ABO antigens and antibody. So these antigens and antibody, once a pool, they have to be make the complex and then reduce the titer of the antibodies. Even giving ABO incompatible, that doesn't have effect on the patient's long term. So we can give without any fear of any ABO compatible platelets to the patient. What will they? You find DCT positive only. That's because of ABO. Otherwise, the patient increment is there. Once the patient like hematoma patients, apart from the ABO incompatible transfusion, if the increment is not there, then we can see for the ABO compatible. So that's the only thing we can able to switch over. Otherwise, ABO incompatible RTPs is very well set and with a good increment for the patient. Yes.
Yeah. One more thing to add about pooled platelets. Considering the cost factor, this can be useful because with pooled platelets, we can use PAS also. With platelet additive solution, we can do leukodepletion of the pool. So there are two techniques. If the blood center is using Buffy code method of component separation, they can actually pull the Buffy code, make a one Buffy code, then separate the platelets. Then you can do the leukodepletion and add the platelet additive solution. In that scenario, this component, pooled platelet, is comparable. You can say comparable to single donor platelets, which will reduce the cost. And what we are observing is in European countries, now there is a trend that they are shifting more towards pooled platelets, which are leukodepleted and with addition of platelet additive solution. Right. So this will be again one more component available to clinicians. There is a single donor platelet. There is a pooled platelet, which is leukodepleted and with platelet additive solution, and a random donor platelet. Thank you.
Yes, yes.
Patients who come for elective surgery.
For red cells or what?
For transfusion. Red cells.
Honestly, it is better the surgeon should probably decide based on what type of surgery it is, what the patient's comorbidities are, what his cardiac status is. Based on that, I guess the surgeon or the anesthetist should decide what it should be. But in general, anything above 8, you probably don't have to transfuse. Below that, you must decide based on the patient's other issues.
In that case, we can decide whether surgery, elective surgery, whatever we are going to do, can be postponed for some time. There are some surgeries which we say it is a semi-emergency, especially in cases of malignancy. We cannot postpone those surgeries. In those cases, we have to transfuse. But hernia or cholecystectomy, all such kinds of surgeries wherein we are doing those surgeries to avoid further complications. In those cases, we can just give some injectable iron. We can boost his or her HB and then do the surgery. That will be a better idea. But in some cases, we can't just avoid giving transfusions. We have to, or we can at least keep the blood ready when the hemoglobin is borderline. And whenever we are seeing that there is some blood loss during the surgery, then we can just transfuse. That can be a better idea.
These injectables, they take how much time to increase 1 gram?
Actually, a month or so, but in 15 days also we can get the results if we are contemplating that the surgery is needed early. Then after 15 days also we can just check once, especially when we are looking at a situation where it is the borderline hemoglobin. So in 15 days also we can try and see whether hemoglobin has improved.
Because the oral takes 1 month to increase 1 gram. Yeah.
In such situations, injectable definitely are preferable. So oral, it will take maybe 1 or 2 months also. Injectable iron preparation, or then whenever there is megaloblastic type of situation, then we can give the injectable B12 and we can improve that hemoglobin.
So with this question, we conclude the session because now next minute will start. Thank you.
Thank you, Dr. R.P. Singh, for moderating the session. Apart from those delegates who are present here, there are almost 192 delegates who are online. So 2 short questions. First is absolute indications of transfusion in anemic patient. Yeah, from online. There are 192 delegates online. So quick short 2 questions only I'm taking. Absolute indication of transfusion in anemic patient.
It is a symptomatic patient. Somebody who's getting giddiness on walking, who's got decompensated heart failure. That is an absolute indication.
Thank you, sir. Second question: can antibiotic be given through the same set, blood transfusion set? So
No, you should not. You should avoid.
Yeah. Thank you. I call upon President, IMA President Dr. Meenakshi Deshpande, Madam. President-elect Raju Variani, sir. Vice President, Secretaries to come on the dais to felicitate the moderators and speakers. Yeah. Dr. R.P. Singh. Dr. Atul Kulkarni, sir, please come on the dais. Before we start the third session, there will be a small tea break. Tea is being served outside the auditorium. I request all the delegates to have a cup of tea before we start the third session on time. Dr. Mukund Penurkar. Dr. Samir Melinkeri, sir. नहीं सर आहे ऑटो ट्रांसफ्यूजन. Dr. Sachin Yadav, sir. Once again, I request all the delegates to have a cup of tea and come back for the third session. We'll be starting the next session on blood transfusion practice from NABH perspective. I request everyone to come back within 4 to 5 minutes.
आणि आमचं पण ते आमची हाईट कमी याची ना इथे एक ठोका बाहेर जाऊन अलका मॅडमना सांगा सगळ्यांना सेशन सुरू. हो हो चालेल.
इकडे करता येईल आपल्याला.
हेच सर दॅट इज अ गुड
थोडं तिकडे जाईल ना.
नाही पण माणूस दिसत नाही बोलणारा दिसतच नाही तिकडे.
माईक असं इकडे येतो ना असं माईक तिकडे जाणार. माईक पण खाली नाही ठेवायला. माईक खाली ठेवला चालू असल्यावरती
नाही आता बरं आहे. जागा
I request all the delegates to be seated, please. We are starting the next session. I request the moderator for the next session, Dr. Snehal Muzumdar, to come on to the dais, please. And I request the panelists, faculty, Dr. Atul Kulkarni, sir, Dr. Milind Belsare, and Dr. Shubhangi Chandage to come on to the dais, please, and be seated on the chairs. The session is on the blood transfusion practice from NABH perspective. It's a very important topic for all of us. So I request everyone to be seated and we are starting the session. Is Dr. Snehal Muzumdar madam here? I request her to come on to the dais, please. नहीं आधी हम थोड़ा वे बसा. Just have a seat. Yes, sir. I also request Dr. Atul Kulkarni to come on to the dais. Okay. Dr. Milind Belsare to come on to the dais, please. Dr. Shubhangi Chandage. Yes. Just before we start the session, there is a pin. Somebody's pin is fallen. It's written CS. If anybody has lost the pin, these pins are very memorable. You know, somebody has given it to you. So it's always an honor to have a pin. So whoever has lost its pin, it's with me. You can collect it later. We are starting the session now. So let me first introduce our moderator for this session of blood transfusion practice from NABH perspective, Dr. Snehal Muzumdar. She has specialization in blood transfusion services. She works at Ruby Hall Clinic. She's a director of blood transfusion services, more than 24 years of experience in this field. She has got special recognitions from Navabharat Stree Shakti Award, Shivan Shakti Corona Warrior Award. Ruby Hall Clinic Blood Bank scored the highest marks as per the report on the assessment of blood bank in Maharashtra, India, published in 2015 by NACO and NBTC. Congratulations. Ruby Hall Clinic Blood Bank was the first in the city of Pune to get NABH accreditation for blood bank. Blood Storage Center was the first in India to get NABH accreditation for the blood storage center. Excellent, madam. Now let me introduce Dr. Milind Belsare, sir. He's an anesthesiologist. He works at Shashwat Group of Hospitals. He's head of the department there and more than 36 years of experience in the field of anesthesia. He's a pioneer in anesthesia for bariatric surgery. He's speaker in many conferences on anesthesia in morbidly obese patients, founder member of labor analgesia team in Pune, did a lot of work to spread concept of labor analgesia, wrote articles on safety in anesthesia practice. Welcome and thank you for coming, Dr. Belsere. Now I come to Dr. Atul Kulkarni. He's the director in charge of JANAKALYAN Blood Bank, who have organized today's sessions for IMA. He's MBBS in Diploma in Pathology from Pune University, Diploma in Transfusion Medicine from CPS Mumbai. He is the internal auditor for Blood Bank NABH, internal auditor for hospitals NABH. He is member of governing body and technical committee of SBTC Maharashtra. He is director JANAKALYAN chain of blood banks and medical services. He is the lead assessor for NABH for the blood banks. He is assessor for NABH for entry-level hospital. His areas of interest mainly is the quality in blood transfusion service, and he is a regular platelet donor himself. Great. So let's now move to Dr. Shubhangi Abhijit Chandagi. She's MBBS DTM. She works for Dattaji Bhale Blood Center, Dr. Hedgewar Hospital, Aurangabad, Maharashtra. She's a chief blood transfusion officer and quality manager. Her experience in this field is more than 16 years. She is NABH assessor for blood centers. She's working as quality manager in Dattaji Bhale Blood Center. She has been doing various presentations on rational use of blood components, bedside transfusion practices, and quality management systems for clinicians. Welcome, madam. Welcome, all of you. And now I give this session to Dr. Mazumdar.
A very good morning to each and every one of you present over here. A very good morning to seniors and friends who are with us online. Around 170 plus people are here online with us. Today morning, this is a Sunday morning. First of all, it was raining. The warm bed was very inviting. Don't go, don't go. Dr. Atul Kulkarni here. He has conceptualized this CME in such a wonderful and thoughtful way. Dr. Atul, Dr. Vacha Sundar, Dr. Tanvi here, and the entire team of JANAKALYAN, they have not only put in hard work, but a very thoughtful work in dividing this session into 6 very practical parts. And thanks to the active IMA under Dr. Deshpande madam, Dr. Kshir Sagar, Dr. Gitanjali madam, who introduced us, Dr. Raju sir, each and every member of the JANAKALYAN and IMA team, together you have put in this educational feast. And I would say that the aroma pulled us out of our beds. And here we are today, okay, attending this session. And this speaks of the volumes that the medical fraternity needs to now give to the field of transfusion medicine. Even a 1 ml of wrong transfusion can be fatal to the patients. Blood transfusion, as Dr. R.P. Singh and even Dr. Melankari said in the previous talks, the dosage is important, the indications are important. So even 1 ml of wrong transfusion can be really fatal. And if the transfusion is avoided, maybe your patient will survive. Maybe your patient will survive. I'm not saying he will. But giving the blood in the correct way, correct dose, correct component, correct type is very vital. And that is where the quality comes in. Okay. Now, most of the moderators would have put this slide in the end with a nice thank you tag. I prefer to put it as my first slide because in India, NABH accreditation is synonymous with quality. And quality begins here. Quality begins in the mind. It has to be inculcated as a habit. It has to come from within us. Nobody should force it from outside. Your accreditation can happen, but your accreditation will only be sustained if each and every employee of yours is not working because the boss will scold him, Because they want to demonstrate things to the NABH assessor during the assessment, or they want to keep that certificate on the wall. Only if each and every employee of yours works in the way they are supposed to work, because they feel that this is the way, this is the correct way of doing about things, then only quality will be achieved and accreditation will be sustained. So this slide is very important, that you must do the things correctly when nobody is watching you. And you should not do it for anybody. You should do it because that is the correct way of going about it. Now, the concept of accreditation in healthcare industry is a relatively new one. Okay. Now, prior to 2000, if anybody would have asked our doctors, what do you think of quality and accreditation for a healthcare institute, accreditation for a hospital? The doctors would say, me. I always give quality service to my patients. Do you question my ability? You want me to prove my ability with a certificate on the wall? I don't think hospitals need accreditation. It's the manufacturing industry maybe. They need this ISO certification, accreditation and all that. Hospitals and doctors always give quality treatment to the patients. But with globalization, post 2000 especially, things have changed very rapidly. A lot of insurance companies are now coming into healthcare. A lot of central and state government schemes are coming up in the healthcare. And now, even the smallest of the hospitals to the biggest of the corporate hospitals are now treating the patients. But the payment is coming from the insurance companies. The payment is coming from the government, made by the government of India or the state government. And now, paisa nahi milega unless you prove that a quality care was delivered. The government, the insurance companies, they now want you to prove that quality care was delivered, and how much you deliver, that much only you'll be paid for it. Now, all the doctors went into thinking mode. The hospital managements went into thinking mode. Accreditation chahiye kya? Haan, abhi accreditation chahiye, because we have to demonstrate what we are doing. The mindset is slowly changing. Abhi bhi na thoda sa wo third picture jaisa hai. We have accepted that accreditation is required, but there's a little apprehension. There's a little fear. It's such a daunting task. Will we be able to manage it? So to overcome that fear, so that the fourth picture becomes a reality where quality goes hand in hand lovingly with the healthcare, the IMA and JANAKALYAN has organized such a session, and many more sessions need to be conducted so that the last picture is our future. Okay, so that is the idea of today's session. Now, I said healthcare in India is relatively a new concept. So NABH came up with the first standards in 2005. They were released in 2006. And after that, every couple of years, they have upgraded till the 4th edition. Now, the first 4 editions of NABH were prescriptive in nature, meaning the emphasis was on infrastructure and processes. Your standard operating procedures, your quality system processes, because this concept of accreditation was new. So we had infrastructure. It's not that we didn't have it, but in that prescribed standard, so that you comply with those standards and the requirements of that standard, we had to make certain changes. The most problematic area I feel was documentation, because we doctors are used to treating patients. Patient aaya, symptoms bola, medicines diya, patient theek ho gaya, we are happy. We never tried to quantify it or document it to that extent. So I think we were doing mostly everything, but we were lacking in documentation, and that is the thing required in NABH, because what is not documented is considered not done. So we had to work on our infrastructure and our processes. After 10-13 years of the first standard being released, NABH also started realizing that now basically the structure and process is in place. Now we need to have a standard which is outcome based. And so in April 2020, the NABH has come out with the NABH standard, which is more outcome based. And for a healthcare industry, the most important outcome is the patient satisfaction. So the current 5th edition of NABH has 10 chapters, 10 chapters, 100 standards, and some 651 objective elements. Now I have used some color codes for the objective elements. Now this is not my choice. This is a choice used by NABH in their standards. And if you see, even NABH has used various levels for these objective elements, because NABH believes, which is the truth, that quality is a continuous process. So the core and the commitment standards, they have to be achieved when a person or an institute goes first time for the accreditation. But the achievement and excellence standards are expected to be complied with when an institute goes for a re-accreditation or for continuation of accreditation. Now, 4 or 5 years after the full-fledged accreditation program was released by NABH, they realized that there are many hospitals in India, smaller ones, mid-sized ones, who are not, and even some large ones, who are not daring to go for the full accreditation. So as compared to the number of hospitals in India, the number of hospitals going for accreditation was very few. So like, like I say, chalo, abhi hum aaj Himalaya chadhte hain, aaj hum Mount Everest ki taraf chal padte hain. Then most of you will say, madam, aap chalo, hum theek hai yahi pe, jahan pe hum hain. Okay. But if I say ki chalo, aaj hum Sinhagad climb karna try karte hain, I think at least a few of you will join me. So that was the NABH idea, to give the taste of quality to people, so that, once they get acclimatized to lesser stringent standards requiring some lesser financial aid, and then they might, once they settle down there, they might think of going for a full accreditation, and they might feel achievable. And the results were quite visible, that yes, more hospitals started going for this entry level certification. There are some hospitals which are less than 50 beds and they plan to stay less than 50 beds, but they do give services to the people under insurance schemes, health insurance schemes, and government insurance schemes. So NABH came with a lesser stringent standard, even lesser stringent than the entry level accreditation, under pre-accreditation entry level certification for small healthcare institutes. So you see, within a very, we must be very grateful to NABH, who is so thoughtful that now currently they have covered such a big spectra of hospitals in such a small duration of time. Hardly 22 years have happened since the concept of quality in healthcare has come in India, and NABH has now in this short span of time created standards for almost all kind of hospitals. Now it is up to us now to see to it that we at least start with the quality. Now, in today's forum, we are going to touch upon the transfusion service requirements, means how you will develop the blood transfusion services in your hospital for the entry level accreditation as well as full-fledged accreditation. And there are two very important topics. One is quality indicators and one is hemovigilance. And without these two words, transfusion services ka improvement cannot be thought of. So I will now hand over this dais or this mic to Dr. Milind Belzare. He's already been introduced. Sir is a director of Shashwat Hospital, and very actively he has participated in not only getting his hospital certified for the entry level, he has prepared the transfusion services too. Sir, over to you.
Thank you, Muzumdar Madam. My sincere thanks to IMA office bearers, especially Dr. Meenakshi Deshpande and JANAKALYAN, especially Dr. Atul Kulkarni. I am going to speak on pre-accreditation, entry-level certification. What are the criteria? So at entry level, the NABH has given 10 chapters, 45 standards, and 173 objective elements. Out of the 10 chapters, chapter 2 is the one which deals with the care of the patients. In chapter 2, regarding care of patients, standard 3 is regarding documentation, which defines the rational use of blood and blood products. The objective elements A, B, C, D, and E deal with mainly blood transfusion services. Now, what are these objective elements? The 3A deals with documentation of policies and procedures which are used as guide for rational use of blood and blood products. 3B relates to governance of transfusion of blood and blood products. 3C is related to the applicable laws and regulations. 3D is regarding the consent for blood donation and transfusion. 3E is about the procedure which addresses the documentation and reporting of the blood transfusion reactions. Now, this topic of entry-level guidelines can be further subdivided into what should be done by each party involved: the hospital management, the blood transfusion committee, and the consultants involved. What is the protocols for sending the blood sample for compatibility testing? What are the precautions that need to be taken regarding the transfusion? Monitoring of the transfusion and treatment of any adverse reactions, and disposal of empty or partially empty blood bags. The hospital management has to start with a memorandum of understanding with a blood center. Nowadays, they use the term blood center instead of blood bank, which is considered as more statutory. So the blood center has to have a valid license. Preferably, it should be NABH accredited. The blood center has to be in a reasonable distance from the hospital, because it should not take too much time for the sample to be taken to the blood center and the blood unit to come to the hospital. The blood center has to ensure that adequate amount of hassle-free, assured, and timely blood components are supplied to the hospital when we have emergency or an impending emergency. Then blood center's scope of services has to match with the hospital's scope of services. For example, if the hospital is planning to start a bone marrow transplant, then you should relate to a blood center which has got irradiation facility. The hospital transfusion committee and consultants. So they decide, fixes the indications of the blood component transfusion. Even though there are national indicators, the hospital has to come up with their rational use of blood component services. They should undertake training of resident medical officers and sisters regarding the protocols of blood transfusion. And there they should also stress upon importance of documentation of consultants as well as resident medical officers. Now, the consultants have to explain to the patients and the relatives the indications of blood transfusion. They have to also inform the relatives if the blood transfusion is absolutely mandatory or there are some alternatives available. And at that same time, the risks which are associated with the blood transfusion also have to be told to the relatives. The consultant has to write in his own handwriting the order of the blood transfusion. This cannot be a telephonic order. This cannot be a verbal order. In that order, he has to write what component is to be given, why it is necessary to give the blood transfusion. That means, for example, because the patient's hemoglobin is low or the patient has bled actively, this indication has to be documented on the paper in his own handwriting. Then he has to write how many units of the blood product has to be transfused, what is the rate at which the transfusion should be given. Are there any precautions which he specifically advocates, or is there any pre-medications which he wants to be given before the transfusion is started? Then patient consent is taken for transfusion. The blood sample is taken for grouping and cross-matching and component reservation. Here, while taking the sample also, it is important that a correct sample is identified by two parameters. One is the patient's, even at the time of collection, one is the full name of the patient and UHID number. In addition, further information of age, sex, and the name of the consultant should also be mentioned. The hospital must have already done in the hospital lab the patient's blood group report, which should also be attached to the case sheet of the patient. Now, this completely filled blood requisition form along with the blood sample is sent to the blood center for blood reservation. Now, when the blood center informs that the blood product is ready and it is time to give the blood transfusion, the consultant issues a note, when that the blood transfusion needs to be given, what are the products that has to be given, and how much is the quantity required. Now, while transferring the blood product from the blood center to the hospital, the cold chain has to be maintained. Now, the two important components are, one thing is thermally insulated bag or the box in which the blood product comes to the hospital. And secondly, the ice pack. The ice pack has to be there to maintain the temperature of the blood product. Now, one important notification here is that the platelet should not contain the ice pack. The platelet function reduces if the ice pack is used. They should be maintained at the room temperature. There should be minimum delay after the blood transfusion is blood product is issued and starting of the transfusion. So the person who goes in to get the blood component has to be instructed that he has to come directly and as soon as possible to the hospital without making any delay in the transport. Then it is duty of the RMO and the staff nurse. The two persons have to check, the resident medical officer and the staff nurse. Both have to relate directly the blood bank and the patient. That means whether it is going right component is going to the right person. So two checks are very important. One thing is identification of the patient, which is done by the full name of the patient, which can be either asked to the patient or seen on the wristband of the patient, and UHID number, which is either on the wristband of the patient or on the case sheet of the patient. So these are the patient identifiers. Then there are two blood bag identifiers, which include the sticker, which contains the unit number of the blood. And secondly, there is a tag, and that means there is a mark which is there on the tube, which is attached to the blood bag. And that is written by the or embossed by the manufacturer of the blood bag. And it is a unique number. It is never repeated. Once the transfusion is about to be given, the doctor also has to check the blood for any visible clots, any turbidity, or any greenish discoloration. All these three make the blood unusable. It should be returned to the blood bank, and another sample, another component has to be asked for. Once again, recheck that the patient consent is appropriate, and then you can think of starting the transfusion. Before starting the transfusion, record the pulse, blood pressure, temperature, respiratory rate, and the time at which you are starting the transfusion. All the hygienic precautions must be maintained while handling the blood or blood product. If the patient has got any medical conditions, such as patient is in failure or is known case of allergic diathesis, then you have to give preemptive medicines such as steroids or diuretics before starting the transfusion. The first 10 minutes, the transfusion should be given very, very slow because you want to watch for any allergic or hemolytic reaction. Patient has to be monitored very carefully, and vital parameters have to be noted on the blood transfusion sheet at every 30 minutes. All the labels which have come on the blood bottle should be attached on the record sheet of the blood transfusion. Managing any adverse event. The first thing everybody has to remember is stop the transfusion. Any minor reaction, chills, fever, patient not feeling comfortable, first thing is stop the transfusion, inform the consultant. First, you treat the signs and symptoms, wait for 30 minutes. If there is nothing happening and the chills and everything settles, you can consider starting the transfusion once again after 30 minutes. And if nothing happens, you can continue it. If there is a major reaction, then the blood bag has to be returned to the blood center. Along with this blood bag, one has to center a post-reaction patient's blood sample, which has to be taken from the opposite arm of the patient, and also the first void urine sample. Along with this, we have to write all the details of what really happened, what was the exact nature of the transfusion reaction, and the transfusion reaction form. So all these further samples along with this form has to go back to the blood bank in order to find out, so that they will find out what really went wrong. We have to also record on the NABH adverse reaction register what happened and how was it treated. Now, if this blood sample has not, if this blood component has not worked, you will require send a requisition for the next sample, for the next component. So in that, we have to specifically mention that the previous attempt has caused this kind of a reaction, so that the blood bank will take adequate precaution while sending the next blood component. For example, they will think of sending a leukodepleted blood. The feedback should be sent to the blood center for each and every transfusion, even if there has been no reaction, because the record keeping is very important, and even small reactions should not be missed. Once the transfusion has gone off successfully, discard the blood bag in the yellow bag like any other infectious biomedical waste. Another 1 hour, we must monitor the patient carefully. After that, the consultant and the relatives can be informed that everything has gone off uneventfully. The thermal insulation bag can be returned to the blood center. All the papers are checked and register is filled. Thank you.
Thank you so much, Dr. Velsere. He has represented the entry-level accreditation or entry-level certification hospitals requirement regarding the blood transfusion services, where the entry-level organization does not have a blood bank of its own or a blood center of its own, and where they have made an MOU with a licensed blood bank. But sir has so comprehensively covered all the points in the transfusion that I would like to emphasize over here that whether you are going for a full accreditation or a entry level certification, or you do not plan to go to any of these immediately, these steps need to be followed in the best interest of your patient and then yourself. Okay, so these are all very, very important steps in transfusion. So whoever is undertaking transfusion, they need to follow these steps meticulously because each step is important. Now, when we were speaking of quality since last 15-20 minutes, those who have now accepted quality, yes, this is my life. Now, how do they measure? अभी एंट्री तो हो गया अंदर, accreditation तो मिल गया, wall पे certificate भी लग गया, अभी हो गया. Now, should I rest back? I think getting accreditation is very easy. Maintaining that accreditation is very difficult. And quality indicators play a very major role. They are the indicators which tell you that when you are walking on the path of quality, whether you are improving continuously or it's status quo or your service is deteriorating. So it is a timely eye opener. And I request Dr. Atul Kulkarni to run us through the quality indicators for the transfusion services.
Thank you, Snehal madam. Since considering the time constraint, I will be very brief. As you know that she has emphasized that you have implemented the system as Belsare sir has told you in about entry level. If you focus on entry level, the NABS says there are no specific mandatory quality indicators. These 2, 3, 4 need to be monitored. It's up to the organization. They have to choose the quality indicators that will be helpful for them to further improve the quality. So they can choose the areas where they feel there is a challenge and they can monitor it. And so it will be useful. So for entry level, there is no specific mandatory quality indicator from blood transfusion service point of view. But definitely, since it's a journey, for entry level also, they should select some of them. For main accreditation, there are indicators definitely. And most common, as you know, we are worried about, and in the previous 2 sessions, we discussed also that blood transfusion can cause reactions. So monitoring blood transfusion reaction is very important indicator, and that is a mandatory one. So any trivial reaction, say it's not like that something serious need to be happened and then you are going to document it. No, it's mild reaction, allergy, fever, that also needs to be documented. And it is described as a percentage. So percentage of transfusion reaction, it can be calculated as number of transfusion reactions divided by number of units transfused multiplied by 100. And this need to be monitored monthly. So second mandatory quality indicator is turnaround time. We are very worried about it, whether it is urgency, emergency, routine. So depending, so we are worried about turnaround time also. So that turnaround time need to be monitored, and how it is defined, because that is very important, how you define the turnaround time. If you think previously in 4th standard, it was defined raising a request and getting a unit. So for example, blood centers like mine, which are standalone, and hospital which are like located at 2 kilometers, then there is a huge turnaround time for transportation. So turnaround time can be extended, and there were confusions between hospital and also how to calculate turnaround time. Now it is defined time taken to be calculated from the time the request is received in the blood bank till the blood is cross-matched or reserved, so that it is available for transfusion. This is how they have defined, and how to calculate. They have said sum of time taken, total time divided by total number of blood and blood components cross-matched or reserved. So again, this need to be monitored monthly, and unit will be in minutes. So these are now, as madam has told, that it's a per outcome based standard. So these are the mandatory one. In previous standard, 2 more were there, but I think this is also a concern for hospital. That is the wastage of blood and blood component. We are worried about it. So this need to be considered. And secondly, percentage of blood component uses is again optional. You can think of it. For wastage, it can be divided. True wastage at the hospital site unit is issued and not transfused, and it can be considered at storage center or blood center site where it is stored but not utilized. So there can be two part about wastage also. And per components we are discussing in various panels. This is the era of component. When I started my journey in this field, the component uses was 20% or max 25%. And now at JANAKALYAN, we are practicing 100% component. So to encourage the hospitals to ask for component, this can be a good parameter in small size hospitals, that they should monitor how much components they are using. So simply a number of component used divided by a number of blood components used. So this is how you can calculate the percentage. So main important, why to monitor all these things? Because we have a passion to give a best quality service, and hence these indicators will give you insight how to improve your service. And as we know, आपल्याला सगळ्यांना माहिती आहे की आपली स्पर्धा ही स्वतःशीच असते. तर तसंच तुम्ही तुमच्याशी स्पर्धा करून you have to improve on this ground. And considering the time, this is called as a benchmark. So you have to set your benchmark and compete with it, comparing with last year ki are baba wastage last year ta itka hota, this is my target for this year. Blood transfusion reaction investigate kele te evde hote, now this is my target. So benchmark should be uplifted. To begin with, you can use standard benchmark, and then later you can define your own and compete with the benchmarks. Thanks a lot.
Thank you so much, Dr. Atul. Very difficult topic, very easily explained. See, what happens is, in your hospital, if you ask for, say, 4 platelets, 2 are transfused, patient gets reaction, you discard the third one. Your assistant doctors or your staff nurses are doing the job. You don't even realize how many units are discarded. You don't even keep a abhi transfusion reaction hua, you treat that case and it's forgotten. But when you keep these as quality indicators, you are actually measuring. And when at the end of the month, these figures come in front of your eyes, are इस महीने में 10 paxels फेंक दिया हमने. Oh, we had this 4 transfusion reactions. So this leads to root cause analysis, and obviously there is then the corrective action taken. When corrective action is taken, we are humans, we start thinking. So automatically we think how we will prevent this, and there lies the quality, the circle is completed. So that is how the quality indicators, they really help us. Easier said than done. We are coming to full-fledged accreditation. The requirements of blood transfusion services for a full-fledged accreditation. Dr. Shubhangi Change, who other than her, she's a quality manager actually working on the ground, and she is the chief BTO of Dattaji Bhale Blood Bank, Aurangabad. So I hand over the mic to her.
Thank you, Snehal madam. Thank you, IMA and Dr. Atul sir for giving me this opportunity. So now everything is ready. Already, sir has explained about the entry level quality indicators are ready. To start a system, any system is very easy, but for maintenance, it's very difficult. So that is the full accreditation. Most of the part is covered. So in full accreditation, that is continual, whatever is clauses are there for entry level, are they maintained? That is mostly checked. So in addition, as Snehal madam has already, she has informed that there are 10 chapters, 100 standards and 651 objectives. So 102 are core, 459 are commitment, and 60 are achievement, and 30 are excellence. What is this, all this? So the core objective elements that are mandatory for entry level and for a full accreditation. So that has to be complied. So commitments are also mandatory for entry level and full accreditation. Achievement objective element is seen in mostly at surveillance. So and excellence at re-accreditation level. So this is a chapter 2 of this NABH hospitals, that is care of patients, and the standard 8 in chapter 2 and that goes to the transfusion services. So in that we have almost 8 elements, objective elements. One of them is core, that is 8B, and 8G and and H are achievement. Rest are all commitments. So she has already introduced us that the color code is as per NABH. So we will go through the commitment. First commitment, that is scope of transfusion services is commensurate with the services provided by the organization. Core B, that is very important, that is transfusion of blood and blood components is done safely. Commitment C is blood and blood components are used rationally. Commitment E is informed consent, also includes informed consent is obtained for transfusion of blood. Informed E is informed consent also includes patient and family education about donation. That is the best for part for transfusion services. And commitment F is blood components are available for use in emergency situations within a defined time frame. As Atul sir said, the turnaround time is very important. Achievement G is post-transfusion form is collected. Reactions, if any, are identified and analyzed for prevention and corrective actions. And achievement H is the organization shall implement a quality assurance program. So it's very easy after entry level to go for full accreditation. So coming to first, it's the scope of transfusion services is commensurate with the services provided by the organization. So in this, most important part is hospital has to ensure that there is adequate availability of blood components available, whether it is in-house blood center or whether it is like blood storage center, attached blood storage center, or you're outsourcing the facility. So the most important points are in this commitment A is like blood center with which you are going to do a memorandum of understanding that should have a valid license and preferably NABH accredited if you are going for NABH. So that is important, even though if they have applied, the date should be valid license date should be available. There should be SOPs or policies for procuring blood and blood components. That is in case of non-availability in that blood center. So how you are going to cater that, and if in emergencies or in massive blood transfusion protocol. There should be SOPs on transportation. That is, Belsare sir has explained in detail. So how the blood is transported. So that SOP facility should be available. And also the recording, temperature monitoring recording, like by data loggers through a shipping carriers, which are used for transporting of blood components. So coming next, we will go for second commitment, that is transfusion of blood and blood components is done safely. So this is the core element, objective element, and it's very important, that is from vein to vein. It starts from donor to the patient. So there should be a format. First of all, there should, as per both of them have said, that the requisition form should be completely filled, including the phlebotomy signature who has drew the sample. So and also there should be written orders, like orally, if someone clinicians ask for blood, that is not recommended. And so written orders, including pre-medications, that are also important. The rate of transfusion is also very important in adults, in pediatrics, in emergencies, and in massive transfusion. What will be that should be individual policy of that each and every hospital. So blood cold chain, that is including safe storage and transport, and then delivery of blood, that is turnaround time, that is from the request to the cross match ready, that is also important. And availability as per the distance, as Atul sir had already explained. Verification of blood components before transfusion, that is proper check, two identifiers for blood component bags and also for patient side, both, including wristband or any barcode system if available. So the last is the monitoring of transfusion reactions in detail. So that completes the core B. This is the format for monitoring. So first initial 15 minutes, next is half an hour, and then hourly. That's the including all vitals, they are monitored. And the person who, the signature of the person who is transfusing the blood, that is also important. So coming to 8C, that is blood and blood components are used rationally. So already in second session, what, when, and where, all the part of this is covered, like what should be the trigger points for packed red cells, platelets, plasma, and cryo, all. So written guidance and written leaflets should be, work instructions should be displayed, and policy decisions, like in casualty, that should be displayed, what will be the trigger factor and when they are to be ordered for blood. So these protocols, like massive transfusion protocols, are also important, and unless and until it is most necessary, then only it is better to not transfuse. That is the guideline, best guideline for rational use, and also avoid single transfusions. So also address the inventory and ordering schedules, whether it is planned or unplanned. Like if each and every hospital should have a surgical blood order schedule, that is for which surgery, what amount of blood they are ordering for blood transfusion services. So that guidelines should be all in the written format and displayed at hospitals. So coming to 8D, that is very important part. That is the informed consent is obtained for transfusion of blood and blood components. It's legal, and it's very important that when should the, most of the time we have a question like when should the consent be taken, what should be included in that, and whether it is necessary for repeated transfusions or which components. So it can be the policy decision, either it can be actual or anticipated, and for how it should be the policy for unconscious patients, pediatric patients, and ICU patients. The most important change in this standard is like, is it necessary for multiple transfusions? So the standard mentions that for multiple transfusions, you can take the consent 6 monthly also, like thalassemia patients are there, any hematological, like if they require multiple, is it needed? But I, as per like advise that even though if standard mentions, it is better to transfuse, like a hospital should have a policy for at least 24 hours So the consent should be taken for each day, but because it is very difficult to retrieve if it is for 6 monthly. So consent can be obtained at first instance, and once in 6 months, it should be has defined validity period, not more than 6 months. Patients, relatives, or guardians should endorse the consent at each repeat transfusion. And what it should include is the most important part, that is risks, benefits, and possible complications of multiple transfusions. And that should be the, like, just not taking the signature of the three of them, either of them is not important. First, we have to inform whatever are risk and benefits and complications. So it should be in the language which the patient, relatives or patient understands. So this is the consent form of our hospital. So 8E, coming to 8E, it is the informed consent also includes patient and family education about donation. So it's very important. Either we can give the leaflets for motivation of donation, or it can be included in the consent itself. Note can be included. So coming to 8F, that is the achievement which is observed during surveillance. The blood or blood components are available. Sorry, it's F, like it's a commitment. Blood or blood components are available for use in emergency situations within defined time frame. So as Atul sir said, that quality indicators, the turnaround time is very important quality indicator. So we have to have a emergency policies, how the blood is going to cross match in emergency, what will be the massive transfusion protocol, how they are going to order, and how it is going to reach the hospitals. So all that is defined in a defined time frame. Even in mass like disasters, what should be the policy of the hospital with the blood transfusion centers? So how they are going to cater all the disasters and requirement of blood transfusions. So even that is also very important. Disaster plan should be ready of hospital plus blood centers. This is the post transfusion form. So coming to achievement G, that is post transfusion form is collected, reactions if any are identified and analyzed for prevention and corrective actions. So we have seen a lot of transfusion reactions which Melankri sir has explained very well. So how the transfusion reactions are noted, how they are informed to blood center, workup is done, that should be given to the hospitals, feedback is collected. Even though if it is uneventful, the feedback has to be collected, and the analysis of that feedbacks to be done, and corrective and preventive actions to avoid further transfusion reactions on part either clerical or it's on the blood bank side, hemolytic, or that should be all classified also. So coming to achievement H, the organization shall implement a quality assurance program. So written program either of the individual blood center or as part of hospital quality assurance program should include quality indicators covering all aspects, that is from vein to vein. Even the blood centers should have EQUAS, that is external quality assurance system. So, it's one of the important proficiency testing program. Hospitals should have a hospital transfusion committee where all the points of reactions and whatever problems they are facing from blood center or blood center is facing from the hospital are to be discussed. And there should be always a hemovigilance audit. So most of the hemovigilance part, Atul sir is going to explain in detail, and Snehal madam is going to give her experience also. So we will not go into deep. Thank you.
Dr. Shubhangi, that was very comprehensive. We are really running short of time. So we will really make it really very fast. Okay. So it's a lunch time. So are we going to continue or are we stopping it here? and open the forum for questions?
No, I think we will make a note just about hemovigilance and we will stop.
Okay.
Yeah. So just want to emphasize one point. We will not go in presentation part, but please note that we have a hemovigilance program in place. India has a hemovigilance program, that is a national hemovigilance program. It is jointly run by National Institute of Biologicals and Indian Pharmacopoeia Commission and all these things. They have a portal, hemovigilance portal, that is in place. Either the hospital or a blood center can register with the portal, and we have to submit each blood transfusion reaction on this portal, so that there will be our data, Indian data, how many units we have transfused, what kind of reactions they are coming. So that will be captured, and that will be helpful for creating policy document for us to add the safety norm, to prepare the what testing needs to be done. So all data that will be useful. So that point I will like to press. Those hospitals who don't have a blood center, they can make a MOU with the mother blood bank and give their reactions in detail in the said format of hemovigilance program. So this linkage will be effective to show the assessor that they are linked to the hemovigilance program, because NABH full accreditation, definitely the assessor will be asking you, are you participating in hemovigilance program? So for them, you have to directly link through your blood center or with the help of a blood bank which you are associated with. You can link it and give compliance to the NABS standards. So please remember this thing in mind, that hemovigilance program is in place, and everybody nowadays with NABH, it's like a compulsion that you have to submit the data. If there is a no reaction, then also you have to file the nil reaction data. And mind well, all the information is kept confidential. They will not come back to you, अरे या हॉस्पिटल मध्ये ही रिएक्शन झाली, या माणसांनी दिली, मग चला आता यांच्यावर केस करू. So all the information that is filled in the portal is anonymous. So I think that's in short about hemovigilance. Thanks a lot.
Yes, in a very short time, a very important program has been explained. But I would rather say, let's forget that compulsory part, because accreditation is voluntary. Let's do it happily, what we have to do, what we must do. I will just quickly show you a good hemovigilance program of Ruby Hall. I'm not going to take more than a minute of yours. See, this is a blood transfusion checklist folder which we have prepared. The two elite speakers today have been emphasizing that we must correctly relate the blood unit to the patient. We must check the blood unit before transfusion. How do we do it without missing any points? So we have introduced this checklist folder at Ruby Hall. So the first step, as sir has said, is writing that the consultant writing the order in the patient's file. Immediately after the order is written, we prepare this checklist folder. Then we take the consent. The first document to go in the consent, in the checklist folder, is the patient's consent, followed by patient's blood group report. That's the second document to go in this folder. Then when the bag is actually issued to the patient, the cross-match and issue report is the third document to go in this folder. And when the consultant actually orders for the blood transfusion, we in the blood bank, we issue the bag with the label. So after the transfusion is done, the label is pasted on this folder itself, and all the patient's vitals before, during, and after transfusion are recorded on this folder. Whatever the doctor and the staff nurse independently needs to check, all those questions are here. So they just have to check and tick mark. One folder will cater to 8 units, 4 on this side and 4 on the other side. So this forms a blood transfusion file inside the patient's medical file. Not a single point is missed, nothing is lost, everything is retrievable in case of an audit or a legal case. And for a 9th unit, you make a new folder. Now this is how we go systematically about it, and this is our hemovigilance team. So we have formed a hemovigilance committee, like a hospital transfusion committee. So the medical director, the nursing director, the transfusion services director, that is myself, and we and the medical coordinators and the nursing supervisors, we form this committee. And the medical coordinators and the nursing supervisors, they are the auditors. and they do not audit their own areas. Okay, so 3% of all transfusions are audited, and they are surprise audits. So what I've observed is that when somebody is being observed, they know that they might be observed, they generally stick to the protocols and things don't go wrong. And this is our hemovigilance audit form. So again, this is a very structured activity. If there is a non-compliance found, it is immediately recorded. The auditors and auditees sign it. The root cause analysis, the corrective and preventive action is recorded. There are monthly analysis meetings, and there is a quarterly hemovigilance committee meeting along with the transfusion committee meeting. So we have included the consultants in the transfusion, the junior doctors and the staff nurses. So everybody is hand in glove with the blood bank, and together as a team, we ensure a good outcome, which is very visible. Yeah, every case of transfusion reaction, delay in starting transfusion, and wastage after issue are included in this hemovigilance program, and the results speak for themselves. Even during the COVID, we had managed to audit 1.7% cases, and we are very happy with the results, and we are increasing the numbers too. Now let me not come in between you and the lunch, and today is Sunday, we all want to go back to our families. So let's now break for lunch. Thank you.
It's not lunch time. Let's have. Yes. आज उपास आहे आषाढीचा. It was an excellent session for quality maintenance. And madam, the last what you showed about Ruby Clinic must be useful for everyone over here. May I now request our president, Dr. Meenakshi Deshpande, to come on to the dais to felicitate all the panelists. First moderator, Dr. Muzumdar, madam. Dr. Atul Kulkarni. And Dr. Changi, madam.
Madam has come from Aurangabad.
Now I request all the office bearers to come.
Yes, now we are going to start with the Doctor's Day celebration. Dr. Meenakshi, madam, please be on the dais. And now I hand over the mic to Dr. Alka Kshisagar, ma'am.
Yes, Dr. Meenakshi, madam, come on the dais. I will request our executive trustee, Dr. Sanjay Patil, sir, to come on the dais. As you know, National Doctors' Day is celebrated in India on 1st of July every year to commemorate the birth and death anniversary of Dr. B.C. Roy. So on 1st July, we had arranged one blood donation camp in association with Abbott Laboratories and Janaseva Blood Bank at Wakdewadi and collected 18 blood bags. And in the afternoon, evening time, we had a webinar on acute ischemic stroke management with 1 MMC point. So IMA Pune organizes Doctors Day award ceremony every year, especially to honor doctors who have inspired us through their dedicated human services over decades. This year, we are felicitating 5 senior members on the occasion of Doctors Day. So all of them are great. So one by one, I'll be calling them and we'll felicitate them and we'll get the message from them. So first one to felicitate is Dr. Vishwas Patil, hand surgeon. So I'll call upon Dr. Padma Iyer, madam, to introduce sir. Yeah, Dr. Vishwas Patil, sir, please come on the dais and okay, she's not there. Yes, sir, please be seated. Sir, please be seated. Yes, Dr. Padma Iyer, madam. I request madam to introduce Dr. Vishwas Patil, sir.
Thank you, Alka madam. It is my dignitaries on the dais and off the dais and all my friends. It's a great pleasure to invite all of you for this award function to commemorate National Doctors Day. And it's my honor and pride to introduce senior hand surgeon and the first hand surgeon of India, Dr. V.S. Patil. And he has done his MBBS in 1967 from University of Pune, BJMC, MS 1971 from University of Pune. He did hand surgery training in UK 1973 to 76 under Dr. David Richmond and Dr. Harold Bolton, and practicing as hand surgeon in Pune since 1977, wrist to fingertips. That is the hand surgeon's definition he has given. And I asked him, he is the first hand surgeon of Pune and probably first hand surgeon in India. A big round of applause to him, please. He has more than 80 papers, presentation, oration, CME lectures at various national conferences. He has 7 papers in international conference. He has publications in national and international journals. His hand clinic is recognized as Education and Training Center for Hand Surgery by International Federation of Societies for Surgery of the Hand since July 1996. And he's a member of Association of Surgeons of India, Association of Plastic Surgeons of India, Burns Association of India. He is the Indian Society for Surgery of Hand, Indian Association of Occupational Health, Maharashtra Orthopedic Association, Indian Medical Association, Research Society of BJ Medical College, Pune, Honorary Hand Surgeon, Diabetic Association of India, Pune. He has given lectures to lay people, industrial workers, paramedics, talks on radio about safety measures in industries, and written articles in local newspapers to increase awareness of hand specialty in the lay public. Over to the OBs for the felicitation. And it is the honor of and pride of IMA Pune to felicitate you on the occasion of National Doctors Day, sir. We are honored. Thank you.
Thank you, Dr. Padma Iyer, madam. Dr. Padma Iyer, madam, she's a practicing surgeon and she's a treasurer of IMA Trust Board and our managing committee member. I just forgot to tell you. So she's the great person. So it's so nice to get introduced by Dr. Padma Iyer, madam. So now I request our president, madam, Dr. Executive Trustee, Dr. Sanjay Patil, sir, and everyone to join the felicitation. Yes. Dr. Varyani, sir, you can come on the dais. And
Patil to Patil.
I think I will talk only about my relationship with the IMA stage. When I came to India in 76, my first lecture was arranged by Dr. Ashok Dikshit. And at that time, I had no transparencies or any material. Topic was neurology of the hand. And just 10 to 15 people on the first row, and the rest of the hall was empty in 76. And most important thing for me was Dr. R.S. Wadia was there in the first row. And that gave me a feeling of full hall. And then I gave my talk on neurology of the hand, because R.S. Wadia was interested in carpal tunnel syndrome. At that time, after 2 years, I operated on first carpal tunnel syndrome, because the awareness of carpal tunnel syndrome, diagnosis, treatment, everything was not known to anybody. Even till I finished my MS, I had not seen a single case or operation of carpal tunnel. What was happening with the general practitioners, or the carpal tunnels were given B1, B6, B12, or intermittent courses, next course, third course. And if they end up with orthopedic surgeon, they were treated as cervical spondylosis and given cervical traction. Nerve conduction studies were not available in Pune at that time. Dr. Tamankar, I think, came in early 80s, and then we started getting nerve conduction studies. But before that, even in UK, we had no nerve conduction studies. Clinical diagnosis we all operated. So that was my first lecture in IMA. Second was in 86, annual refresher course. Third was in 89 in refreshers course. In 25th IMA Maharashtra State Conference. And that time I was awarded best paper, Dr. P.V. Gokhale Rolling Trophy. That paper was on pressure dressing for the burns of the hand. So I have used this platform as a basic to learn, improve, and take the academic and clinical research line. And then I was totally drenched in it throughout my life till this time. I have each and every case paper right from day one in my clinic with follow-up records, pathology reports, nerve conduction report, everything is there. And almost 15,000 transparencies. My camera used to be in the hospital all the time. It is still there. It's not being used now. Now we have digital cameras and all that. That was Asahi Pentex. And after that, in 89, I spoke in front of the College of GP's FCGP exam. 92, there was a seminar. There I spoke in clinical practice. And this is my association with the IMA. I'm grateful to IMA for giving me a chance to start my academic career, IMA and then Research Society of BJ Medical, where I started making mistakes, improving it, picking it again, getting criticism from audience. And that's how really one progresses. Unless you face criticism from your colleagues, you become alert. So next time you present the same work, you are improved. Now these Burns papers I have presented almost in 10 to 15 cities in India and in International Federations Congress in Paris. That was only became possible because encouragement was given to me by that trophy for the same paper. And this is my association with the IMA. I'm very much grateful to this forum, this body. This is my alma mater. Thank you.
Thank you, sir. Thank you very much. Now we'll be announcing the second awardee, Dr. Abhay Mule, Senior Physician. Sir, please be on the dais. Sir, please come on the dais. And Mrs. Abhay Mule, Mrs. Mule, please come on the dais. And to introduce Dr. Abhay Mule, I will call upon here Dr. Raju Varyani, sir, our President-elect. Yes, sir. Hello. All the awardees, please, faculties who are going. Dr. Virendra Oswal, please look into them and kindly take them to lunch area. Otherwise, they'll be remain. So thank you very much. Now I request our President-elect, Dr. Raju Varyani, sir, to introduce Dr. Abhay Mule, sir.
Dr. Abhay Mule, Senior Physician. Sir was born in Barshi, district Solapur. He did his primary studies, primary schooling in Madhya Pradesh, Sagar district. Then he came to Sangli Junior College. He was there at Wellington College, Sangli. Then he passed his MBBS from BJ Medical College in 1969. From 1970 to 1975, sir was medical officer at a PHC in Kolhapur district. Then in 1976, sir came to Pune, where he practiced in Kothrud area as well as Salisbury Park area. He was also working at Bharatiya Samaj Seva Kendra, Family Clinic and Orphanage from 1981 to 1997. Sir has also done FCGP in 1990, that is Fellowship of College of General Practitioners. Sir has also done Child and Adolescent Psychology from Jnana Prabodhini. Now sir has reduced his practice. Now he practices only in the morning times. His interests are literature. Sir was awarded with Sahitya Visharad in Marathi and Rashtra Bhasha Kovid in Hindi. He has interest in music, listening to ghazal songs. Also, he loves traveling, discovering incredible India. He does regular cycling and he is a muscle trainer. Congratulations, sir.
Thank you, sir. Please be seated. Now I request our President, Madam, and Dr. Sanjay Patil, sir, Executive Trustee, to felicitate sir and It's Mrs. Mule, madam. Yeah. Yes, sir. Sir, would you like to speak for a? Yes, yes, sir. Yes, sir.
I'm not used to public speaking. I accept these felicitations with pleasure and humility. I come here, reached this place because of various persons. First and foremost was my father. Because of his liberal views, I could accept all individuals or patients as an individuals with idiosyncrasies and without prejudgment. Second thing is that allowed me to continue having very clear dialogues, frank discussions with patients from the fourth generation, that is from 15 to 30 years of age, who can talk with me about whatever goes on in their life, including premarital sex, use of bhang, ganja, weed, whatever. But they can talk with me. This was because I got my views from my father. All my teachers from the primary school at Sagar, Patwadhan High School at Sangli, Wellington College were great, and they laid the foundation of a very solid education. Stalwarts at BJ Medical College in those days, Dr. Manohar Joshi, Dr. Bodhe, Vihar Bhave, Sri Bhave, all doctors in medicine, Dr. Sardesai, all these doctors taught us the clinical skills. At Ratnagiri, I did my internship where there was paucity of good medical officers, and we had X-ray unit, but no plates. And we had a dental unit, excellent dental unit, but there was no dentist in Ratnagiri at that time. There was no MD internal medicine in Ratnagiri at that time. So difficult cases, we used to read ourselves and do all the mistakes and some successes. Again, when I went to primary health center, it was so remote that the STVs also did not reach there for 5 or 6 months a year, during an year. And I was left to treat patients with great responsibility, supposed to be a medical officer in charge primary health center, without any investigative facilities. And even the last year of my work, we had about 72 obstetric admissions, many of which required to be referred because we had no time to keep them with us. So during all these days, I probably honed my clinical skills. In 76, I started practice, 2 sessions at Kothur, 2 sessions at Salisbury Park. Added in 83, the Bharatiya Samaj Seva Kendra, there in the orphanage, Dr. Naurange guided me in pediatrics. And because of my interests, I did some what you call ongoing lecture series in IMA on psychiatry as well as diabetes medicine. After that, I did Dhyan Prabodhini's child and adolescent psychology. And now I'm interested in multiple patients with multiple problems, different systems, and counseling. And otherwise, my interests have been told. In primary health center work, I faced the 73 famine or drought in Maharashtra. I will request you people to read a book by P. Sainath, a journalist. The English name is Everybody Loves a Good Drought. मराठी भाषांतर आहे दुष्काळ आवडे सर्वांना. तर ते वाचण्यासारखं पुस्तक आहे, an insight into the drought. Also, I came to know the rural India, where a postman used to start from his headquarters, distributing mails and money orders for 3 days on foot, come back collecting those things 3 days and resting on the 7 days. There was no transport, nothing. So I have seen real rural India during those days. General practice, of course, is a bit unconventional. I started in those times general practice without giving injections and tried to charge patient consultation fee of 5 rupees, which took a long time for acceptance by the patient. But ultimately it did work. I am very much indebted to the Indian Medical Association because I could do FCGP because of the prodding of some people, including Dr. Navarangi again, and then all the what you call CME programs which have kept me updated. So I thank IMA. This is a what you call significant event for me because it comes from IMA. I am thankful to all of you. That's all.
Thank you, sir. Nice to hear you from primary health care experience, because nowadays in the remote places you get the experience. It's really a wonder. And that time it was too tough. Now it's okay. We are having all the facilities in primary healthcare center also. So thank you very much, sir and madam. So yes, sir. Please be seated in the audience, and you can go for the lunch also if you are in a hurry on the second floor. Yes, sir. Yes, sir. Please. Yeah. Sir, please be seated. Please. Yes, sir. Thank you. The next award goes to Dr. Lily Joshi, madam, a senior physician. So, madam, please come on the dais. We made you waited. Sorry for that. And I request Dr. Jayan Navarange, Survey Sarva of IMA Pune, to come on the dais to introduce his classmate, Dr. Lily Joshi, madam. Yes, madam. Please. And Mr.
अरे डॉक्टर नरेंद्र प्लीज कम ऑन द डायस. ते डॉक्टर आहेत पण आम्ही शिवी म्हणून नाही वापरत आहे, पण ते नॉन मेडिकल आहेत. वेलकम सर. मी सर्व वगैरे काही नाही आहे, पण चांगलं सुरू आहे त्याचं. So it's my great pleasure to introduce my classmate and a very close friend and a very leading physician and a very good person, Dr. Lily Joshi. मी मराठीत एवढंच बोलेन की आपण सगळे उच्च विद्या विभूषित आहात, आपण सगळे, पण ही विद्या वाचस्पती आहे. So whatever is written by her in the biodata, I know much more beyond that. And I remember the days right from my SSC board examination when she was a ranker in the SSC board. This is not there in the curriculum vitae. So she is within the first 10. And I think she was, if I remember well, a student from Renuka Swarup, MES Mulinche Bhavi School. So ranker from that time, she completed her schooling from Renuka Swarup High School, then MBBS from BJ Medical College. Always has been a very sincere and top ranker medical student, and did her MD from there. And I remember her dissertation was those days the renal biopsy and true cut biopsy, which was comparatively new that time. These things are not there in the biodata. This is the close association we used to have. We used to be very afraid. This was without ultrasound. We used to be very afraid of doing a renal biopsy. And in pediatric, we used to have the system of open renal biopsy those days. So you can imagine what times we had to face. As what Dr. Abhay Mori said, these were the tough days, but we had to go ahead with the time, and now it has become so easy. And she cleared MD with me only. Of course, she was married by then to Dr. Narendra, who have worked several years as a, I think, research scientist and a manager with Thermax, and a great help to all of us and a great idol for us. She did her BA, MA, PhD in Sanskrit literature. She pursued the course of Indology and written books on both medicine, lifestyle, as well as in literacy language of Sanskrit and Marathi. She's a practicing consultant physician since 1976, has conducted several camps for spreading the patient awareness and given talks about health issues in different groups, and written extensively in various media about health and disease, with particular emphasis on preventive aspects of lifestyle related diseases and behavior therapy. Has given talks on various groups of citizens, many adolescents to super seniors. Has published 12 books and several booklets about common health problems, lifestyle modifications, travel, and other subjects. She has written extensively in the news media Sakal and Saptak Sakal also. आणि त्यांची काही गाजलेल्या पुस्तकांचा फक्त मी उल्लेख करतो, टाइम शॉर्ट आहे. आजची बदलती 40 हे मला वाटतं 20 वर्षापूर्वी ते लिहिलं असेल. त्याचं उद्घाटन रिलीज वॉज डन बाय डॉक्टर सरदेसाई. आनंदी शरीर आणि आनंदी मन कोवळ्या आई बाबांसाठी, म्हणजे now the satellite families are there. I think I should read this book about parenting because I had to guide my patients. मसाई आणि ते उत्तम पद्धतीचं प्रवास वर्णन पण लिहिते. आणि त्याच्यामधले मसाईंच्या देशात पर्यटन एक संजीवनी, आणि मग आपण संस्कृतकडे येऊया. ते त्यांनी खूप अलीकडे केलेलं आहे हे सगळं. मला खूप कौतुक वाटतं की okay, so that's great, isn't it? 25 years after doing the practice, after doing MD, so maybe in the year 2000. So I was younger when I did my LLB in 1995. Not bad. So महाभारत व्यक्ती आणि संकल्पना, कथा उर्वशीची, ह्या त्यांनी आपल्या मायथॉलॉजीवरच्या लिहिलेली पुस्तक आहेत. आणि मला काल वाचताना आनंद वाटला की रिक्रिएशनल रनिंग म्हणून मी विचारलं की रनिंग कधीपासून करते, because it's a field of my interest and I have not written a single article also. So she said that she would be giving one booklet to me. I hope you have not forgotten that. आणि गेल्याच वर्षी करोनामुळे प्रतिकारशक्ती, आपण सगळ्यांना आमच्या पेशंट्सला सांगतात इम्युनिटी वाढवायला काहीतरी द्या. तर इम्युनिटी वाढवायला काही औषध नाही असं माझं स्वच्छ मत आहे, पण तिने एक चांगलं पुस्तक लिहिलं, प्रतिकारशक्ती कशी वाढवाल. मला खात्री इट इज थ्रू लाईफस्टाईल ओनली. आणि प्राचीन भारताचा उज्ज्वल इतिहास ही त्यांनी लिहिलेली विविध विषयांगी विविध रंगी असं हे बहुमूल्य व्यक्तिमत्व आहे. आणि त्यांना एबली साथ दिलेली आहे डॉक्टर नरेंद्र यांनी. त्यांची दोन्ही मुलं अमेरिका स्थित आहेत. आय एम हॅपी टू से दॅट आय एम व्हेरी प्राऊड टू बी देअर डॉक्टर in their young infancy when they're critically ill. And both of them are in USA now, well settled. One is in Google, still working in Google. Now Apple. So एका पाठोपाठ एक कॉम्पिटिशन चालू आहे. मला वाटतं त्यांची नावं केदार आणि मानसी आहेत, इफ आय फॉरगेट नॉट, बिकॉज आय एम नॉट मेट देम फॉर इयर्स टुगेदर. थँक यू व्हेरी मच अँड आय एम व्हेरी प्राऊड that IMA gave me this opportunity to introduce you. Thank you.
Thank you, sir. Yeah, now I request our President Madam and Dr. Sanjay Patil sir, the Executive Trustee, and Dr. Navarange sir to come join the felicitation.
एक महत्त्वाचं विसरलो, she had worked on our managing committee also for some time, for 4 years. So I should not have forgotten that. And we have our two classmates sitting on the back side, one Dr. Pune and Dr. Meera Mole. When is Pune there?
Congratulations, madam. Madam, would you like to speak a few words?
Yes.
Yes. Let it be. Yeah.
Physicians, gynecologists, and pediatricians have to talk a lot. So, namaskar. आजच्या या 1 जुलै निमित्तच्या प्रेस्टिजियस पुरस्कारासाठी IMA नी माझी निवड केली, याबद्दल मी अत्यंत आभारी आहे. याच्या अगोदर पुण्यातले अनेक ज्येष्ठ आणि श्रेष्ठ असे डॉक्टर या पुरस्काराचे मानकरी आहेत. अगदी गेल्याच वर्षी माझेच 2 क्लासमेट्स डॉक्टर जयंत नवरंगे आणि डॉक्टर श्याम दामले यांनाही हा पुरस्कार देण्यात आला होता. आणि या दोघांचं IMAच्या विकासासाठी केवढं मोठं योगदान आहे हे आपण सगळेच जाणतो. तर अशा या मान्यवरांच्या मालिकेत VS पाटील सर आहे तिथे. तर मलाही आमंत्रित करून IMAने माझा मोठा सन्मान केलाय आणि त्याबद्दल माझ्या मनात 2च भावना आहेत, कृतज्ञता आणि नम्रता. आणि त्यांच्या सहित मी या पुरस्काराचा स्वीकार करते. 1976 साली मी प्रॅक्टिसला सुरुवात केली कन्सल्टंट फिजिशियन म्हणून. म्हणजे हे आत्ताचं चालू 46वं वर्ष आहे. या सिनियरिटीचा फायदा घेऊन किंवा आत्ता मला ही संधी मिळाली आहे म्हणून मी आपल्या तरुण पिढीच्या ताज्या दमाच्या डॉक्टरांशी 1-2 मिनिटं संवाद करू इच्छिते. अनफॉर्च्युनेटली इथे मला ताज्या दमाचे डॉक्टर्स खूप कमी दिसत आहेत. पण या ऑनलाईन ते असणार आहेत. 192 मगाशी होते. ओके. सो त्यांच्याशी थोडंसं बोलू इच्छिते. तर मला माहिती आहे तरुण मित्रांनो की तुमचं वैद्यकीय ज्ञान खूप अद्ययावत आहे आणि हर घडीला विकसित होत जाणारं तंत्रज्ञान आणि नवीन नवीन साधनं, उपकरणं ती वापरण्यातलं तुमचं कौशल्य मोठ्या परिश्रमाने तुम्ही साध्य केलेलं आहे. आणि या दोन्हीचा उपयोग करून भरपूर काम करायचं आणि मस्त करिअर बनवायची या विचाराने तुम्ही सगळे भारलेले आहात आणि ते साहजिकच आहे. पण या सगळ्याच्या केंद्रस्थानी तुमचा पेशंट असला पाहिजे. मगाशी मी ते NABH एक्रेडिटेशन बघत होते आणि त्याच्यात सुद्धा त्यांनी म्हटलं होतं पेशंट सॅटिस्फॅक्शन इज द प्रायोरिटी. मला खूप बरं वाटलं ते वाचून की पेशंट त्याचा एखादा अवयव किंवा एखादी सिस्टीम नव्हे तर पेशंट ॲज अ होल, एक समग्र व्यक्ती म्हणून पेशंटचा विचार हे महत्वाचे आहे. मित्रांनो, वैद्यक व्यवसाय हे आपलं एक विहित कर्म आहे, ज्याला इंग्लिशमध्ये कॉलिंग म्हणतात, वोकेशन म्हणतात. आणि श्रीकृष्णांनी सांगितलं की विहित कर्म करताना या कामातनं मला काय मिळणार आहे हा विचार करू नका. मा कर्मफल हेतुर्भू. आणि पुढे जाऊन ते म्हणतात मा ते संगस्तु अकर्मणी. जे करायला नको आहे, जे निषिद्ध आहे ते तुम्ही करू नका. हे डूज अँड डोंट्स तुमच्या प्रॅक्टिसमध्ये येऊ देत. आपल्या कामावरची अचल निष्ठा, प्रामाणिकपणा, वागण्या बोलण्यातलं सौजन्य, सरळपणा आणि पारदर्शित्व या मूल्यांचा विसर पडू देऊ नका. अशा तऱ्हेने तुम्ही काम कराल तर त्याची दखल तुमचे पेशंट्स, त्यांचं कुटुंब आणि पर्यायाने समाज घेतोच घेतो. आणि त्याच्या पाठोपाठच येते लक्ष्मी आणि प्रतिष्ठा, पैसा आणि मान मरातब याची प्रत्येक तरुणाला आकांक्षा असते. पण ही सगळी आपल्या कामाची आनुषंगिक फलं आहेत. तत्फलम आनुषंगिकम असं म्हणतात. तर कुठलंही काम करताना आपल्या क्षमतेनुसार जास्तीत जास्त चांगलं मी केलेलं आहे हे समाधान हेच त्या कर्माचं फळ आहे. मित्रांनो, आज आयुष्याच्या या टप्प्यावर मी अत्यंत समाधानी आहे. बस एवढंच सांगायचं होतं. आणि पुन्हा एकदा IMAच्या पदाधिकाऱ्यांचं धन्यवाद देते आणि आपला निरोप घेते. नमस्कार.
थँक्यू व्हेरी मच मॅडम. सर जसे म्हणाले की विद्या वाचस्पती, खरंच त्याचा अनुभव आला आणि खरंच आपले शब्द इतके गोड आहेत, आपल्या सारखेच गोड आहेत. थँक्यू व्हेरी मच मॅडम. येस, प्लीज बी सीटेड इन द ऑडियन्स. We'll be taking one photograph after another two bodies. And now we are calling on the dais Dr. Kalpana Balivant Madam, Assistant Medical Officer of Health PMC, as a 4th awardee. And to introduce her, I will call upon Dr. Aarti Nimkar Madam on the dais. And Dr. Balivant sir, he's a doctor. He's an anesthetist. Yeah. Yes, sir. Please be on the dais. Yeah. Yes. Welcome. Now I request Dr. Aarti Nimkar Madam to introduce Dr. Kalpana Balivanta Madam. Actually, she is very much familiar with our IMA team and IMA members.
Thank you very much, Alka. And I am very much thankful to IMA that they give me the opportunity to introduce a very strong and powerful lady of the Pune Municipal Corporation, Dr. Kalpana Balivant Madam. Her graduation is MBBS from the Mumbai University and post-graduation in Diploma in Public Health from the Mumbai University again. She has done her MD in the Preventive Medicine from Pune University and lecturer. She was worked as a lecturer in PSM in Maimar College, Medical College, Talega, and joined the Pune Municipal Corporation as a resident medical officer in December 1998 and worked as a ward of medical officer from 2003 to 2009. And also she has worked in swine flu pandemic control unit in 2009 to 2010. And this is her work progress in the PMC, how she was working in the different departments. And another departments are the reproductive child health program. She has worked as a chief immunization officer in PMC, chief insect-borne diseases control program, and presently she is working as assistant medical officer of the health and appreciated appropriate authority of the PCPNDT of the Pune Municipal Corporation. This is a very important post for the gynecologists and radiologists. Yeah, very important committee. And everybody are very scared about this PCPNDT. But after coming the Balivant Madam on this post, everybody is very relaxed and working with the tension free. And also she has worked as a bogus doctor show Mohim program. This is also a very important program. In charge of she has done in the COVID care center as a nodal officer, and the most importantly, she has worked as in charge of the crematorial and the burial ground of the PMC in COVID pandemic. It was a very, very tough job she has done in that time. And she has managed all the COVID positive dead bodies. And we cannot imagine how she has done this job. And she proved herself very strong and strength of the woman, that whatever the work given to the woman, she can do it faithfully and very nicely. And I am very proud of her. As a woman, she has stand still, strong on her deputation. Thank you. And it is our privilege to felicitate her on this Doctor's Day program.
And Madam is very helpful. Anytime you call her, she will be there and she will guide us and help us. So now I request our President Madam, Dr. Meenakshi Deshpande Madam, and Dr. Sanjay Patil Sir, Executive Trustee, to felicitate and Dr. Aarti Nimkar Madam to join the felicitation of Dr. Kalpana Balivanta Madam and Dr. Balivanta Sir.
तुमचं झालं रजिस्ट्रेशन?
हो झालं. 5 जणांचं झालं. नमस्कार. लिली जोशी मॅडमनी मराठीत बोलल्यामुळे मलाही एनकरेज झाले मी मराठीत बोलायला. सर्वप्रथम IMAचे मी मनापासून आभार मानते की त्यांनी एवढ्या मोठ्या या अवॉर्डसाठी माझं सिलेक्शन केलं. मला हा अवॉर्ड आज दिला. मी पूर्वाश्रमीची म्हणजे फार काही नाही, मी DPH म्हणजे डॉक्टर पूर्वी होते. आता मी डॉक्टर नाहीये. आतापर्यंत मी सगळे जे ऐकले सिनियर्स ते सगळे ते डॉक्टर्स आहेत आणि डॉक्टर राहतील. पण आम्ही पूर्वी डॉक्टर होतो. मी पब्लिक हेल्थमध्ये मागची 25 वर्ष पूर्णपणे सार्वजनिक आरोग्य आणि ॲडमिनिस्ट्रेशनमध्ये टोटली काम करते. पूर्वाश्रमीची कल्पना आनंदा लाडी माझ्या बाबांचं नाव म्हणजे माझं माहेरचं नाव. शाळा कॉलेज मुंबईतलंच माझं सगळं. LTMC आणि GS मेडिकलमधून माझं शिक्षण झालं. आणि दोघेही आम्ही पुण्याला शिफ्ट झालो कारण छोटंसं निमित्त म्हणजे बॉम्ब ब्लास्ट वगैरे व्हायला लागले आणि मूल लहान होतं 6 महिन्याचं. तर म्हटलं नवीन भविष्य मुलांना द्यायचं आहे तर लेट अस हॅव सम पीसफुल सिटी लाईक पुणे. सो वी सिलेक्टेड पुणे अँड वी मायग्रेटेड टू पुणे इन 1993. त्यानंतर माझं MD PSM BJ मेडिकलमधून झालं. डॉक्टर प्रतिनिधींसारखे अतिशय सक्षम आणि खूप म्हणजे त्यांच्याबद्दल मी काही बोलूच नाही अशा मॅडमच्या अंडर माझं MD प्रिव्हेंटिव्ह मेडिसिन झाल्यामुळे पब्लिक हेल्थ म्हणजे काय हे ॲक्च्युली त्या मॅडमनी आम्हाला शिकवलं. शी इज दी टीचर इन पब्लिक हेल्थ. त्यानंतर महानगरपालिकेत जॉईन झाल्यानंतर माझा प्रवास बराच खडतर होता. मॅडम म्हणाल्या त्याप्रमाणे इट्स व्हेरी डिफिकल्ट. पार्डन मी ऑल मेल हिअर, पण लेडी ऑफिसरसाठी खरंच इट इज व्हेरी डिफिकल्ट टू सर्व्हाइव्ह इन अ सिस्टम लाईक कॉर्पोरेशन. बट वी कुड डू इट. म्हणजे काही चांगले पण लोक मिळाले त्यामुळे ते करता आलं. आणि बऱ्याचशा वेगवेगळ्या विभागांमध्ये काम करण्याची संधी मिळाली. पब्लिक हेल्थमध्ये जे शिक्षण घेतलं ते काही प्रमाणात इम्प्लिमेंट करता आलं. त्याचा मला भयंकर आनंद आहे. आणि सर्वात महत्त्वाचं आता या डायसवरून मी माझ्या डेड बॉडी मॅनेजमेंट कोविड यासाठी जी माझी टीम होती त्या सगळ्यांचं या डायसवरून मी मनापासून आभार मानेन, कारण का त्यांच्या सहकार्याशिवाय ते शक्य नव्हतं. आणि मी अगदी प्राऊडली सांगेन की इतर सर्व कॉर्पोरेशन्स किंवा इस्टॅब्लिशमेंटमध्ये काहीतरी इश्यूज डेड बॉडीचे झाले, पण पुणे कॉर्पोरेशनची एकही डेड बॉडीचा काहीही इश्यू झाला नाही. आणि आम्ही खूप सक्षमपणे आणि 24 तास जागे राहून आम्ही ही एकूण एक त्या धर्माची त्या वयाची जी डेड बॉडी मॅनेजमेंट होती, जर बरियल असेल तर बरियल होतं, क्रिमेशन होतं, ते आम्ही खूप डोळ्यात तेल घालून पार पाडलं. त्यात कुठलाही धार्मिक राजकीय काही इश्यू होऊ दिला नाही. आणि सायंटिफिक सगळे आम्ही गाईडलाईन ज्या होत्या मिनिस्ट्री ऑफ हेल्थ आणि फॅमिली वेलफेअरच्या त्या तर पाळल्याच, पण बाकी जे इश्यूज होत होते की मिसप्लेस होत होत्या डेड बॉडीज, या रिलेटिव्हची त्या रिलेटिव्हला गेली, हिंदूची मुस्लिमला गेली, असे बरेच काही कॉर्पोरेशन्समध्ये इश्यू झाले, पण आपल्याकडे काहीच असं झालं नाही.
8,500 ते 9,000 डेड बॉडीची मॅनेजमेंट आमच्या संपूर्ण टीमने केली आणि त्याच्यामध्ये प्रायव्हेट हॉस्पिटल्सचं पण खूप खूप योगदान आम्हाला मिळालं की त्यांनी ऑनलाईन डेथ पास करण्यासाठी परमिशन आम्हाला सहकार्य केलं आणि आम्ही जी काही सिस्टीम बसवली होती त्या सिस्टीमला प्रायव्हेट हॉस्पिटल्सनी आणि डॉक्टर्सनी पण खूप चांगला प्रतिसाद दिला, खूप चांगलं सहकार्य केलं. तर या डायसवरून मी त्या सर्वांचे मनापासून आभार मानते की एवढ्या मोठ्या डिझास्टरमध्ये तो डिझास्टर झाला नाही आणि आपल्याला छान काम करता आलं. बस एवढंच म्हणेन की आई बाबा, माझी भावंड, त्यानंतर लग्नानंतर माझे मिस्टर, बळीवंत फॅमिली, माझी 2 मुलं, एक मुलगा आता US ला आहे, एक बरोबर आहे. आणि या सर्व परिवाराच्या सपोर्ट शिवाय कोणीच म्हणजे पुरुष तर नाही, बाई तर नाहीच उभी. मी तर म्हणेन माझ्या 2 डोमेस्टिक हेल्थची सुद्धा मी मनापासून या डायसवरून थँक्स म्हणते की त्यांनी माझं घर माझ्या ॲब्सेन्समध्ये सांभाळलं म्हणून मी काम करू शकले. तर आय एम व्हेरी थँकफुल टू ऑल दोज टीचर्स अँड ऑल माय असोसिएट्स who have helped me come all the way in my career. I'm very thankful and grateful to IMA again for honoring me with this award. धन्यवाद, मनापासून धन्यवाद.
Thank you very much, madam. Please be seated in the dais. Now, मला खूप आनंद होतोय की मी आता मराठीच बोलायला लागले कारण सगळेच मराठी बोलताय. थोडंसं इन्फेक्शन लागलं असावं, ते पण इंग्लिशमध्ये शब्द आला बरं का. तर आता आपण ज्या सत्कार मूर्तींना आपण डायसवर बोलवतो आहे ते दुसरे तिसरे कोणी नसून आमचे इमिजिएट पास्ट प्रेसिडेंट डॉक्टर BL देशमुख, यंग डायनॅमिक प्रेसिडेंट, जे गेल्या वर्षीच आपल्या इथून प्रेसिडेंट म्हणून आता 31 मार्चला त्यांचं हे टेन्युअर संपलेलं आहे. तर आय कॉल अपॉन डॉक्टर BL देशमुख सर ऑन द डायस आणि त्याबरोबरच त्यांच्या मिसेस मंदाकिनी देशमुख मॅडमना पण मी बोलवते ऑन द डायस. अँड टू इंट्रोड्यूस such a great personality, I call Dr. Geetanjali Sharma, our honorary secretary, and she's also young, dynamic, so budding IMA member. Thank you.
Thank you, Dr. Alka madam. मॅडम म्हणाल्या की मी इंट्रोड्यूस करणार आहे. बापरे, मी काही इंट्रोड्यूस वगैरे करणे इतकी मोठी नाहीये. इनफॅक्ट इट इज माय रिअली ऑनर to say a few words about BL देशमुख sir. 80व्या वर्षी 18 वर्षाच्या माणसाला लाजवेल असा उत्साह म्हणजे आमचे बाळासाहेब. अतिशय उत्साहाने काम करणारे, कधी चेहऱ्यावर थकव्याचा लवलेश नाही आणि फक्त स्वतःच गालातल्या गालात हसणार नाही तर इतरांकडे, मॅडम म्हणाल्या इन्फेक्शन पसरत चाललंय तसं इन्फेक्टिव्ह हास्य सगळ्यांच्या चेहऱ्यावर फुलवणारे असे देशमुख सर. आणि म्हणूनच त्यांना सगळेजण आम्ही प्रेमाने म्हणतो बाळासाहेब. आय एम रिअली प्रिव्हिलेज्ड that I work as joint secretary when he was the president last year. So under his leadership, I learned a lot of things. Many aspects about IMA, but more than that, organizational skills, disciplined working, and most important is how to win hearts of everyone. शाब्दिक कोट्या करणं हा त्यांचा छंद आहे. मीटिंग मध्ये बसल्या बसल्या अशा सहज 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 मराठीत ते शाब्दिक कोट्या करत जातात आणि त्यामुळे एखादं सिरियस वातावरण होऊ पाहत असेल तर तिथे हास्य कल्लोळ उडतं आणि एकदम सगळं वातावरण छान होऊन जातं. इट वॉज अ व्हेरी चॅलेंजिंग टाइम्स वेन ही बिकेम प्रेसिडेंट बिकॉज इट वॉज कोविड टाइम्स. आता बळीवंत मॅडमनी जे सांगितलं त्यावेळेला IMMचे प्रेसिडेंट म्हणून देशमुख सर आले. एक लक्षात घ्या, फिजिकल मीटिंग्स करणं हे त्यांना सोपं होतं, पण 80व्या वर्षी ऑनलाईन मीटिंग्स मध्ये स्वतःला कन्व्हर्ट करणं, ते टेक्निक आणि ती टेक्नॉलॉजी समजून घेणं. ऑनलाईन ते वेबिनार करत असताना मध्येच मला विचारणं की बरोबर चाललंय ना सगळं, म्हणजे इतकं ते मन लावून त्या गोष्टी करायचे आणि प्रत्येक गोष्टीत ही पुट हिज हार्ट आणि त्याच्यामुळे ते टेन्युअर इतकं सुंदर झालं आणि आम्ही सगळ्यांनीच ते खूप एन्जॉय केलं. कुठलाही कधीही गडबड गोंधळ नाही, व्यवस्थित प्लॅनिंग, एक ब्ल्यू प्रिंट त्यांच्या मनात नेहमी तयार असायची आणि ते विजन प्रमाणे काम करत जायचे आणि आमच्यातल्या प्रत्येकातले गुण हेरून नेमकं त्यांना कसं एनकरेज करायचं आणि त्या माणसाला कसं पुढे आणायचं याचा विचार त्यांनी केला. आणि ही लिडरशिप क्वालिटी इज वन ऑफ द बेस्ट क्वालिटीज फॉर द होल टीम टू वर्क टुगेदर ड्युरिंग दीज चॅलेंजिंग टाइम्स. आणि म्हणून मला वाटतं जे काही आपण अकॅडमिक प्रोग्राम केले, मग मल्टीकॉन असेल, स्टेट लेवलची मेडिको लिगलची कॉन्फरन्स असेल किंवा इतरही जे सोशल अवेअरनेस प्रोग्राम्स असतील, सगळे सक्सेसफुल झाले. त्यांच्याच डोक्यातल्या एका अभिनव कल्पनेनी टीचर्स डेच्या दिवशी आम्ही पुण्याच्या मेडिकल कॉलेजच्या सगळ्या डीनना सन्मानित केलं. डॉक्टर्स डेला असंच डॉक्टर्सना, सिनियर डॉक्टर्सना सन्मानित केलं. या सगळ्या कल्पना या त्यांच्या मनातूनच यायच्या. मी असं म्हणेन की IMA हे त्यांच्या नसानसात अगदी रक्तात भरलेलं आहे आणि IMAच्या विचारांनी ते भरलेले आहेत. आणि असं ते छान एक संयोग असल्याने त्यांचं छान काम आपण बघतो आहोत. ही इज द इमिजिएट पास्ट प्रेसिडेंट, जे मॅडमनी सांगितलं. ही इज अ लाईफ मेंबर ऑफ IMA अँड CGP. He is also FCGP. He is honorary secretary of GPA. He has been assistant director of CGP. He has been honorary secretary CGP IMA Maharashtra State. He is into practice as family physician since 1970. He has also worked as honorary medical superintendent at Sanjeevan Hospital for 5 years, and he has been felicitated as excellence in clinical practice as well. आज आपण त्यांचा सन्मान करतोय तेव्हा मॅडम एक 4 ओळी कवितेच्या माझ्या कवितेतून सरांचं थोडं वर्णन करते. ऋषितुल्य व्यक्तित्व असे, ऋषितुल्य व्यक्तित्व असे प्रेरणादायी हरहुन्नरी, सहवास आपला घडे जास, सद्विचारच उमले अंतरी. काव्यशास्त्र विनोद बुद्धी, काव्यशास्त्र विनोद बुद्धी दैवी देणगी आपल्यावरी, काव्यशास्त्र विनोद बुद्धी दैवी देणगी आपल्यावरी. हास्यमुखी ना लोपे कधी, रुग्णास सखा हा धन्वंतरी. कर्मण्येवाधिकार असते, कर्मण्येवाधिकार असते गीता सार सदा तव उरी. कर्मण्येवाधिकार असते गीता सार सदा तव उरी. आषाढीचा दिन सोन्याचा, आज आषाढी एकादशी आहे. आषाढीचा दिन सोन्याचा, विठू रखुमाई हीच खरी, विठू रखुमाई हीच खरी. आज माझाच हा सन्मान मला वाटतोय की मला सरांबद्दल 4 शब्द बोलायला मिळाले. अतिशय कलासक्त मनाचे सर आहेत. आपण कधी प्रेसिडेंट चेंबरमध्ये गेलात तर तिथे एक म्युरल आहे IMAच्या बिल्डिंगचं केलेलं. हे सरांनी डोनेट केलेलं आहे. त्याच्यातून ती कलासक्त वृत्ती दिसते. सर, आज आपला सन्मान IMA तर्फे होतोय आणि मला ही संधी मीनाक्षी मॅडमनी दिली बोलण्याची, त्याबद्दल खूप खूप धन्यवाद.
आमच्या कवयित्री सेक्रेटरीने खूपच कौतुकाचे शब्द सादर केलेत. मलाही 2 त्यामुळे स्फूर्ती आली. बाळासाहेबांचा माझा परिचय खूप वर्षाचा आहे. IMAत आम्ही दोघंही यायच्या अगोदरपासून उत्कृष्ट जनरल प्रॅक्टिस केली. अगदी सगळ्या पेशंटची, सगळी फॅमिलीची सगळी माहीत असताना जे आपल्याला पूर्वी आदर्श जनरल प्रॅक्टिस होते त्यातले ते एक आहेत. आणि अजूनही त्यांच्या पेशंटचे, त्यांचा संपर्क असतो, फोन येतात, त्यांचे नातेवाईक येतात. हे खूप अचंबित आहे. किती डिव्होशन त्यांनी जनरल प्रॅक्टिसमध्ये केलं असेल याची कल्पना आपल्याला यायला हरकत नाही. असं हा आदर्श जनरल प्रॅक्टिशनर माझा मित्र आहे, मला अभिमान आहे.
नमस्कार सर. सर, तुम्हाला आपण आता सत्कारासाठी इथे बोलवत आहोत. मॅडम तुम्ही पण या. डॉक्टर नवरंगे सर आणि डॉक्टर हळबे सर या. सर, डॉक्टर मराठे सर, डॉक्टर जोशी सर, पद्मा अय्यर मॅडम, राजू वरियानी, डॉक्टर आरती निमकर मॅडम. आपल्या IMAच्या इमिजिएट पास्ट प्रेसिडेंटचा सत्कार होतोय. या मॅडम वगैरे. थँक्यू मॅडम. आता मी डॉक्टर BL देशमुख सरांना विनंती करते की त्यांनी 2 शब्द बोलावेत आणि आम्हाला उपकृत करावं. देशमुख सर या.
धन्यवाद गीतांजली फॉर काइंड वर्ड्स अँड वंडरफुल पोएम. नमस्कार. आज आषाढी एकादशीच्या निमित्ताने सर्वांना शुभेच्छा. डॉक्टर डेच्या निमित्ताने होणाऱ्या या सत्कार समारंभाबद्दल मी निवड समितीचे तसेच IMA पुणे शाखेचे सर्व कार्यकारिणीचे मनापासून आभार मानतो. या रद्द सत्काराने मी अक्षरशः भारावून गेलेलो आहे. माझा सत्कार हा मी 50 वर्षाहून अधिक रुग्णसेवेसाठी आहे व ज्या रुग्णांनी मला त्यांच्यावर उपचार करण्याची संधी दिली त्यांचा मी ऋणी आहे व त्यांच्या ऋणातच राहू इच्छितो. या प्रसंगी जेव्हा मी IMAने मला काय दिले असा विचार करतो तेव्हा असे जाणवते की IMAचा मेंबर म्हणून मी जे योगदान IMAसाठी दिले त्याच्या कैक पटीने मला IMAने दिलेले आहे. आज मला IMAचे महाराष्ट्र शाखेचे आजी माजी पदाधिकारी तसेच IMA HQचे पदाधिकारी MMCचे पदाधिकारी नावाने ओळखतात. हे माझे भाग्य आहे आणि हे केवळ IMAचे सभासद म्हणूनच शक्य झाले. अदरवाईज डॉक्टर BL देशमुख म्हणून मला किती लोकांनी ओळखले असते. IMAमध्ये केलेल्या सर्व पदामुळे माझ्या ज्ञानात खूपच भर पडली. त्याच्याबरोबर व्यावहारिक समज पण खूप वाढली. माझ्यातील नेतृत्व गुण वाढवण्याची संधी मिळाली की जसं मल्टीकॉन, IMA फायनान्स डायरी, ML कॉन एक्सेट्रा. थोड्याफार प्रमाणात का होण्यास सहभागीपणा आला. चिकित्सक व चौकसपणा वाढला. सध्याची कर प्रणाली कर्मचाऱ्यांच्याकडून सामंजस्याने व सद्भावनेने काम करून घेणे इत्यादी महत्त्वाची स्किल विकसित झाले. या सर्वाहून महत्त्वाचे म्हणजे तुमच्यासारख्या असंख्य डॉक्टरांशी मैत्री निर्माण झाली. पुढील 2-3 पिढ्यांचे समव्यावसायिक, फॅमिली फिजिशियन्स, स्पेशालिस्ट, सुपर स्पेशालिस्ट, सर्व पास प्रेसिडेंट व मॅनेजिंग कमिटी मेंबर संपर्कात आले. त्यांच्याशी जवळीक व आपुलकी निर्माण झाली. IMAमुळे माझा लौकिक वाढला व माझे जीवन समृद्ध झाले असे मी समजतो. या सर्व प्रवासात माझी पत्नी सौ मंदा हिचा मोलाचा वाटा आहे व माझा मुलगा शंतनू व मुलगी शिल्पा यांचे प्रोत्साहन यामुळेच मी सर्व करू शकलो. माझे सर्व सिनियर्स डॉक्टर बुतकर, डॉक्टर नवरंगे, डॉक्टर सारडा, डॉक्टर हाळबे, तसेच डॉक्टर पाटील, पद्मा अय्यर, डॉक्टर नेने, आरती निमकर, डॉक्टर मराठे, शहाडे, डॉक्टर राजू वर्यानी, सुनील इंगळे, डॉक्टर श्याम दामले, अलका क्षीरसागर मॅडम, या सगळ्यांचे मला मनापासून आभार आणि धन्यवाद देतो. आज सर्व सत्कार मूर्तींचे पण मी या निमित्ताने अभिनंदन करू इच्छितो. धन्यवाद.
थँक्यू सर. गेल्या वर्षी मी सरांच्या बरोबर सेक्रेटरी म्हणून काम केलं. डॉक्टर सुनील इंगळे आणि आम्ही दोघांनी काम केलं. 1 वर्ष कसं गेलं ते कळलं नाही आम्हाला. आणि सरांनी इतकी आम्हाला मुभा दिली होती की त्यांना आपण सांगायचं सर असं असं. आणि अजून सुद्धा आता 31 मार्चला सरांचा टेन्युअर संपलं, परंतु रोज एकदा तरी सरांचा सकाळी मला फोन येतो, मॅडम तुमचा आवाज ऐकल्याशिवाय मला काही माझा दिवस पुढे जात नाही. तर हे सरांच्या एक मोठेपणा आहे की त्यांनी असं मला नेहमी म्हणतात, हो मॅडम, मॅडमला पण ऐकू येतं की नाही मॅडम? हो, मग मॅडम तिथेच असतात. सो थँक्यू व्हेरी मच. या आता मी ऑल द awardees please come on the dais along with your better halves. Please come to the dais and all our IMA managing committee and yes please come. Yeah, one group photo and then everyone will disperse for the lunch, and again we'll be coming here at 2:15. 2:15 we'll be starting the session, so please come. second floor there is a memento. असू दे. ओके द्या घ्या उपरनं घ्या. हे घ्या. या.
Request everyone to join for lunch on the second floor, Kelkar Hall. Yeah. We will be starting the post-lunch session right at 2 o'clock. So requesting everybody to have lunch and come back. Post-lunch session will be started at 2:15.
एक आनंद मिळाला एवढंच आहे सांगायचं. त्यांना व्यवस्थित बोलले. सुनील सर काढा आमचे. हम एक्सेलेंस अवार्ड मैंने मेरे दिया तो मैं भी खड़े रहता. कितनी अच्छी बोली. बोलो काय किती सुंदर बोला. किती कौतुक. अब सुपरलेटिव हम सब लोगों को नीचे डाल दिया. नहीं सर नहीं मैडम ऐसा कुछ नहीं. बहुत अच्छा मन से बोले. मैं बोले अरे सर का इंट्रोडक्शन नहीं कर रहे. होल आपका टेन्यूर के बोल रहे. फिर बाद में शी वोर द स्पेक्स एंड शी सेड मैं बोली सर का इतना ही काफी. Then she said everything आपका प्रोग्राम.